Zu viel Stress vergrößert das Angstzentrum im Gehirn. Bewegung und die richtige Ernährung helfen vorzubeugen. Lernen wir unsere mentale Gesundheit zu stärken. Es lebe das Leben. Helsana.
Auf dieses Bild hat die Wissenschaft über 25 Jahre lang gewartet. Es sind die ersten richtigen Aufnahmen des neuen James Webb Weltraumteleskops.
Das Teleskop funktioniert besser, als man erhofft hat. Das ist wirklich ein unglaublicher Erfolg und entsprechend ist auch die Erleichterung groß.
Das Ziel der Mission: kein geringeres als die Astronomie zu revolutionieren. Das Webb-Teleskop ist das bisher größte und leistungsstärkste Weltraumteleskop. Ein Milliardenprojekt mit jahrzehntelanger Vorbereitung. Schon 1996 beginnt die NASA mit der Planung. Später stoßen die
Welcome to the Swiss ESC Update 2024 in Basel. I'm Christian Müller, I'm the director of the Cardiovascular Research Institute in Basel, and it's my great pleasure to welcome you on behalf of the scientific committee to the 5th edition of the Swiss ESC Update. Of course, those of you here in our lecture room and all of you that will join this important educational meeting online. I want to start by, of course, thanking the members of the scientific committee that represent the university hospitals all over Switzerland that have helped to design the program and that have been very careful in selecting the best speakers for the different topics, the different specialties within cardiology. It's an enormous task that we have asked the speakers and the discussant. It's their task to summarize for you and for my clinical practice the most important studies that have been presented during the one of the hotline sessions at the ESC in London. As you might know, the ESC was an enormous success with more than 32,000 participants, 12 hotline sessions, a very high number of very high quality studies published in the New England Journal of Medicine, in Lancet, in JAMA. And of course, it's impossible for an individual to get all the information because there are so many parallel sessions, so many things ongoing, and therefore the task of these individuals, the speakers today, is to summarize the most important content for you and for me. They do so within a discussion, so it's highly interactive, and again, we are very thankful that we have experts from all university hospitals that will act as discussants and moderators. You've seen the program. We have 5 sessions today. The first 3 sessions will be dedicated exclusively to the hotline presentations at the ESC. Then in the 4th session, we will give you an update on 2 of the important ESC guidelines that also have been presented for the first time at the ESC, the new ESC guidelines on hypertension and the ESC guidelines on peripheral artery disease and aortic disease. And then in the afternoon, the 5th session is dedicated to the future, and very important experts and very important topics covered. Just to give you a teaser, we will have women health in cardiology, one of the really important new areas where a lot is happening, and we will have machine learning in medicine. Having said that, all this is only possible also thanks to the support of the Swiss Society of Cardiology. So this meeting has been organized under the auspices of the Swiss Society of Cardiology, and it's particularly nice that the Swiss Society of Cardiology is represented by Professor Felix Tanner. Felix is working at the University Hospital in Zurich, is acting as the past president of the SGK, and I think returns to his alma mater today. And so I'm very happy that you are able to give your welcome speech on behalf of the SGK. So enjoy the meeting. We want to try to make it as interactive as possible, so please join the discussion moderated by the experts. Thank you, Felix.
Thank you very much, Christian. It's a particular pleasure to welcome you here in Basel on behalf of the Swiss Society of Cardiology. It is the ESC Update Symposium, and you know that our society adopts the ESC guidelines. But not only those, we also adopted the ESC core curriculum, and lately we started to adopt the subspecialization curricula and started with that of the EAPCI, and this is now the basis for our first Schwerpunkt program. Now you heard it from Christian, I am very happy to be back here in Basel because I studied here in this room, and it's just fantastic to be back. I cannot say more than that. And I also don't want to prolong this artificially here. We have a fantastic program ahead of us, and we have fantastic presenters and speakers and discussants, and let's just start with it. I would like to invite our first speaker. This is Dr. Nisha Arenya. She will talk to us about the imaging aspect of the Congress. Please, Nisha.
Thank you. So thank you very much, Felix, for the introduction. Christian, thank you for the invitation. It's a pleasure to be here. The first topic is cardiac imaging, and I would like to focus on artificial intelligence in cardiac imaging. So in recent years, there have been made a lot of effort on AI in cardiac imaging. Currently, we are used to automatic tools to calculate the LV function, mass, and strain, not only in echo, but also in MRI and CT. The studies today are more focusing on disease detection, and this is what I would like to present in the next minutes. One study is the Proteus study, which was presented in the hotline sessions, and the second one, the Delilate MR, which was presented in the late-breaking science sessions. So Proteus is a prospective randomized control trial evaluating the use of AI in stress echo. So you all know that stress echo is the most used modality to identify ischemia and coronary artery disease. However, the diagnostic accuracy varies significantly. It ranges from 60 to 94%, especially due to the operator's performance and experience. So here AI may add a vulnerable tool and help us to have a better accuracy. The authors of Proteus were able to publish in JACC Cardiovascular Imaging 2022 the feasibility of this tool. It is an AI-based tool which can detect ischemia with stress echoes. And this specific tool is called EchoGo Pro. Today, the aim of this study is a prospective evaluation of AI using this specific tool on patients' pathway and outcome in real-world practice. So the methods is, this is a multi-center randomized control trial in adults undergoing a clinically indicated stress echo from 20 NHS sites across the UK. They randomized 1-to-1. We had one control group which received the stress echo protocol according to the local policy, and the interventional group were clinicians who sent their echoes to the AI and received an analysis report. Patients were excluded, you see it on the right side, if they had more than a moderate valvular heart disease, LVOT obstruction, if the patient had significant comorbidities and a life expectancy less than 12 months, and patients who had already cardiac surgery and also coronary artery graftings. Patients were also excluded with congenital heart disease. The patients were followed up at 3 and 6 months after inclusion. The primary outcome of the study was the evidence of severe coronary artery disease or an event within the 6 months. And they also tested the non-inferiority to clinical decision in intervention compared to the controls. In the secondary analysis, they examined the non-inferiority in pre-specified subgroups. Here we see the results of the baseline characteristics of 2,341 patients. The age was in median 63, and almost half of the population was female. 20% of the patients had pre-existing coronary artery disease. The stress echo protocol was mainly dobutamine, about 74% of the population received it, and 1/4 had exercise testing. They also used in 75% contrast agents. The number of wall motion abnormalities was low. It was 9% in the control group and only 7% in the interventional group. Overall, 85 patients were referred for invasive coronary angiography. These were 36 from the control and 49 from the interventional group. However, the adjudicated as correct number was much lower. Here you see the primary endpoint, and the area under the curve was 0.55 for the control group and 0.63 for the interventional group without any significant difference. The sensitivity was low, about 55 and 64, and the specificity was very high at 99. However, the numbers were again without any significant difference between the both arms. So in summary, the interventional arm did not meet the pre-specified non-inferiority criteria. In the subgroup analysis, there was seen only one difference, and this was in the site activity. They found that the interventional arm meets the pre-specified non-inferiority criteria only in centers with low volume stress echoes. So in conclusion, AI augmentation did not meet the pre-specified non-inferiority for appropriate refer to angiography compared to standard group. However, AI may help the clinicians in performing stress echoes in low volume centers. This study is in press for publication in New England Journal Medicine AI. The second study I would like to present is the Delineate MR study, deep learning for echo analysis, tracking, and evaluation of mitral regurgitation. This isn't published for circulation. So as we all know, MR is the most common valvular heart disease, affecting about 24 million people worldwide. And patients with a relevant MR have a poor quality of life and a high mortality. For detection, we all know that echo is a method of choice. However, there is a substantial inter- and intra-observer variability. Having a second look, for example with an AI, may help to improve our accuracy. And these are the aims of the study. The most important aim was to develop and validate a specific deep learning model to classify the severity of MR. They also looked whether multiple echo views may lead to better performance compared to the single echo view model. And in the end, they looked at an in-depth analysis of the differences between the cardiologist and the deep learning model for MR assessment. This was a retrospective analysis of echo images performed in the New York region. They all were done in academic echo laboratories and mainly used Philips machines. The internal population consisted of patients coming from the Columbia University and their outpatient clinics, and the external population was recruited from the Weill Cornell Medical Center. They excluded, again, patients with congenital heart disease, but also patients with left ventricular assist devices, patients who had already a mitral valve repair or replacement, and of course, if the echo quality was not good enough. They recruited about more than 60,000 echo data, which were choose for the internal data set and then divided in 3 groups. The one group, about 43,000 patients, were used to train this model, and then it was validated in about 9,000 echoes and tested again in another 9,000 echoes. The external data sets consisted of 8,200 echo and patients. Here you see the clinical pathway. First, the cardiologist had to decide which of these echo views is relevant to find and assess the mitral regurgitation. In the second step, the echo was, also each clip was then classified as mild, moderate, severe, or non-MR. The final diagnosis was made by multi-parametric decision of the cardiologist. Both the echo views and the label of the cardiologist was used to develop this deep learning model. The patient's characteristics show the age of the patients in the internal group of 64 years and in the external group of 60 years. The majority of the population had none or only mild mitral regurgitation. Only a population of 6% had a moderate to severe MR. In mean, the left ventricular ejection fraction was preserved and the left ventricle was not dilated. The most common combined valvular disease was moderate or great aortic stenosis and mitral regurgitation. Here you see the model agreement. In A, it's shown the internal validation, and B shows the external validation. On the horizontal direction, you see the AI model prediction, and on the vertical, the cardiologist's clinical interpretation. Overall, the exact agreement between the deep learning model and cardiologist was 82% in the internal testing and 79% in the external testing dataset. This figure presents the ROC and PR curves. In A and B, you see the ROC curves, and C and D, the prediction recall curves. A and C present also patients with moderate or greater MR, and the other both figures the patients with severe MR. And the last description is the red line is the external validation group, and the black one, the internal. So as you can see here, we have a great accuracy. The model could identify most of the patients, and we have an area under the curve of 0.98 and 0.99 in both groups. The PR curve performed better in moderate than in severe MR. So I would like to summarize the other results of the study. They could also identify that the multiple approach is much better than a single view model, and they identified cardiologists' misdiagnosis in 29% of the cases. However, I have to say here, these was mostly mild mitral regurgitation. So in conclusion, the presented deep learning model demonstrates a strong generalizable performance in the classification of MR using echo studies. And this approach has potential to improve MR diagnosis compared with human interpretation alone. I thank you for the attention, and looking forward for the discussion. Thank you.
Yeah, thank you very much. You selected very interesting studies with very reasonable patient numbers, I have to say, for imaging studies. It's quite considerable. Now, do you know what the Core MD project is?
Sorry, once again. What
the Core MD project.
No.
Yeah, that's okay.
Okay.
Because up to yesterday, I also had no idea. But this is something very important. And this is a European Unity-sponsored program which has the intention to define criteria for such softwares as you just presented. I mean, criteria regulating the clinical evidence which should underlie the clinical use. Mm-hmm. So far, the European Union has no criteria defined for this purpose.
Yeah, right.
So we are in a very uncomfortable situation, because in principle you can just sell such a software and you can use it, and this situation is not regulated by the European Union. So I just know that because I discussed with Alan Fraser, and he was leading this project together with Frank Rademakers.
Okay.
And they prepared a paper. This paper is going to be published soon, and will give recommendations to the European Union.
Oh, interesting.
Now, my question to you after this quite long introduction is, would you use this software in your practice, or would you not?
I think it depends where you work and if you have specific supervisors or not. If I'm alone working on my own and I don't have that much experience doing stress echoes, then I would be happy to have a second opinion, I think. On the other side, sometimes we have mitral regurgitations, which are very hard to quantify. It could also be helpful in these cases. Mm-hmm. So I think I would if we had more data.
Yeah, this is exactly the situation I was pointing at with my prolonged introduction, because it is conceivable when such softwares are on the market and can be used, that colleagues use it to make up for missing training.
Right.
And that's, I believe, not really desirable, isn't it?
We are not on that place right now. We have to learn a little bit more about these features, I think.
There are obviously questions from the auditorium, which is fantastic.
So, Nisha, thank you for your earnest presentation. In the first study that you presented, did I understand it correctly that AI directly sent the patients to coronation program, or it was not supervised again? When cardiologist, it was a direct transfer to the catheter?
No, these were always cardiologists. You had a group of the controls which was mainly driven by the cardiologist, and the interventional group got analysis report, but then decided if they should go or not. It was always the cardiologist's decision. Yeah.
Are there other questions?
I have also a brief question or a comment.
Yes.
Isn't it surprising that the primary endpoint occurred and 3 and 4% of all patients only? Isn't the study just significantly underpowered to tell us whether this works or not in clinical practice?
Absolutely. Yeah, thank you very much for this question. This is absolutely right. We have a very low number of patients with positive results. And they were also discussing on the ESC, why is it like that? Maybe the pretest probability was low. We don't know. I don't have any numbers. It could also be due to COVID, because it was in the time frame, and they had long waiting times, and these were all elective patients. It could be. And on the other side, we have now a lot of medical therapy in patients with ischemia. It could be that they just got medication and were not referred to the angiography. So in the end, yeah, it is maybe underpowered. Yeah.
Marco?
Thank you very much for the very nice presentation.
Thanks.
For discussion. Actually, I would like to have a sort of follow-up observation to the stuff that Felix has said. So your interpretation of the first study is formally correct, but the reason why non-inferiority was not met, because the study was not properly powered.
Yeah.
If you look at the numbers, they were always in favor of the intervention group.
Yeah.
Across expertise of numbers, their side with quartile capacity. Then in the low quartile, in the first quartile, that was statistically significant in favor of intervention, but to manage it, in favor of intervention throughout the board.
Yeah.
So my comment is, why should you not rely on that?
Yeah. Absolutely right.
Double checking what you were really thinking.
Absolutely right. Yeah. Thank you for this comment.
Regarding the first very interesting study, I'm not an echo specialist, but I have an intrinsic interest in echo still. You showed us that, as we always see, operators with low experience, low volumes, I think it was up to 370 stress echoes per year, when I remember correctly. There they saw a trend towards a benefit.
Sorry, here. Yeah.
Was there more information on which variables? Were they worse or didn't perform as good as the others, or can this be used for training?
Yeah, thank you for this question, but I have really no answer, because the study was not published yet, and I just listened to the session. It could be that it can be used for further training, of course, but I don't know.
But if you should, allow me to do not share your opinion in this, because when we want, maybe I'm wrong, but my feeling just is, when you rely your training, or at least part of your training, on such a software, it should be validated, and we should know exactly how accurate it is in various patient groups. And apart from all that, there are other basic criteria which we don't know now, because you were just attending the session and the paper is not published. But I wonder whether the major part of these echoes was the butomean stress echoes.
Right.
So one very important question here is, did they meet the requirements for the target heart rate? Because if they don't, they lose a lot of sensitivity. And I realized that they used atropine in a relatively high percentage of patients, which is a good sign. This tells me that probably they were striving to reach the target heart rate, but that's one of the major problems here, which is a very basic problem.
Absolutely.
And the software never replaces these technical aspects of the examination per se.
That's right, but the idea behind it was to test this IE in a clinical practice.
Sure, I'm not against that. I'm just calling for some caution with these things.
Absolutely right. Okay.
No other questions? Okay, we started early, so we can finish a
Yes.
bit early. Thank you
Perfect.
very
Thank
much
you very
again.
much. Thank you for the discussion. Thanks.
So thank you very much again, Sha, for this brilliant talk about two very interesting studies. And now I can welcome the second speaker, Jan van der Stuwe. He's attending physician here at the University Hospital in Basel, and we are looking forward to your presentation about prevention. Thank you very much.
Thank you very much for the introduction. Thank you for the invitation, Christian. It's my pleasure today to not report on these subgroups, but on prevention. So let's see. Muss ich selber noch? Das noch nicht. Soll ich selber? That one, yep. So this is what I want to be talking about today, prevention. Some hotline sessions on this topic. And there's three topics that I want to cover today. So the first being beta blockers post-myocardial infarction, the second topic being timing of antihypertensive medication, and lastly, risk prediction models. So let's jump right in with beta blockers after myocardial infarction. I think this is something that we do in our everyday to-day practice. A patient comes in, has a large myocardial infarction. He gets a beta blocker based on these data from 1981, 1982, showing an impressive reduction of the primary outcome, mortality. And these were patients with large myocardial infarctions, ventricular dysfunctions, and pathophysiologically it made sense to give these patients beta blockers. We had suppression of ventricular arrhythmias, we had improvement of adverse remodeling, better oxygen supply. But in the modern reperfusion era, we're much quicker treating these myocardial infarctions. And 4 years ago, a Danish nationwide cohort study actually showed us maybe patients who have a small MI with a normal ejection fraction don't profit from beta blocker therapy. And earlier this year, the REDUCE AMI trial was published, showing something very similar. These were patients who were recruited right after myocardial infarctions. They had an ejection fraction of 50% or more, and they were randomized to beta blocker therapy or no beta blocker therapy, and we saw no difference in the primary outcome of death or new myocardial infarctions. So now comes the ABYSS trial. Now this was a prospective randomized, open, blinded endpoint study. It had a non-inferiority design with an absolute margin of 3%, and patients were excluded if they had other indications for beta blockers, such as hypertension, HFrEF, angina, ischemia, or arrhythmias. So the trialists took 3,700 patients who were stable post-MI patients. So on average, these patients had an MI that was 3 years ago. And these were patients who were on chronic beta blocker therapy and an ejection fraction now not over 50%, but in this case over 40%. And they were randomized in a one-to-one fashion to either continue beta blockers or beta blocker interruption, and the primary endpoint was a composite MACE of death, MI, stroke, or hospitalizations for cardiovascular reasons. Now, when we look at the baseline characteristics, they're pretty similar as it was a randomized trial. I just want to point out two things. The first thing is that the median ejection fraction in both groups was 60%, and around 23% of patients in each group had an ejection fraction between 50 and 40%. So when we look at the primary outcome, after a median follow-up of 3 years, we can see that the primary endpoint, the hazard ratio or risk difference, crosses the pre-specified margin of non-inferiority of 3%, and therefore the interpretation of this study would be that the interruption of beta blocker treatment was not non-inferior to the continuation of beta blocker treatment, and this was true for the intention to treat analyses, but also for the protocol analysis. When we look at the separate endpoints, death, MI, stroke, and hospitalizations, we can see that the first three were pretty rare, making up around 20% of all endpoints, and there was no real difference between the groups. But hospitalizations for cardiovascular reasons was the endpoint that was driving this primary endpoint. It made up 80% of all endpoints. So when we look at these hospitalizations, we can see the reason for this was mainly angina, ischemia, repeat angiography, and maybe to a lesser degree, percutaneous coronary interventions. Now, the authors also looked at subgroup analyses. They looked at patients with ST segment elevation and non-elevation myocardial infarctions. They looked at the time between MI and randomization. They looked at the patients if they had an ejection fraction above or below 50%, and if the patients had baseline hypertension or not. And with respect to the hypertension, the authors saw there might be a difference here, so let's look at these subgroups more in detail, and that's what they did. So in the red line and blue line, these are two graphs of patients who had baseline hypertension. In red are the patients where beta blockers were stopped, and in blue, the patients where beta blockers were continued. And the authors saw a blood pressure increase of around 4 millimeters of mercury at 6 months between these two groups. And when they calculated the absolute risk difference, they actually found a slightly significant result with 0.03. Now, this was a subgroup analysis. We have to interpret this with caution, but I think we need to think about the blood pressure effect of beta blockers. Now, the authors obviously also looked at the quality of life, because we often hear from patients who are on beta blocker therapy, I'm so tired, I'm not motivated anymore. And interestingly, using the EQ5D questionnaire, they saw absolutely no difference in the quality of life after stopping beta blockers. After 6 months, after 12 months, they were exactly the same. So in summary, stopping the beta blocker therapy was not non-inferior to continuing beta blockers. However, 80% of these events were driven by cardiovascular hospitalizations, angina, repeat angiographies. There was no real effect on MI, stroke, and death, but these were very small numbers, so it has to be interpreted with caution. Interestingly, quality of life was similar between the groups. And maybe we should start thinking about the long-term effects of beta blockers with respect to hypertension, because we saw there was an increase in blood pressure, and maybe down the line in 10 years, there would be a difference in outcomes. Now, this was also a non-inferiority design. The REDUCE AMI trial was a superiority design. We can also argue which design is better, but thankfully for us, there's a lot more data coming. We got 5 more randomized trials who are going to look at the same question. But I think that there are a subset of patients who don't necessarily benefit from beta blocker therapy. Now, the next topic is timing of antihypertensive medication. 2010, we had the large MAPEC trial, and 2019, the HYGEIA trial, from the same trialists in Spain, who saw a really impressive reduction of their cumulative endpoint, which were hard outcomes between 40 and 60%. 2 years ago, the authors from the TIME study in the UK tried to reproduce these events, but as you can see here, the graphs are exactly identical, so they saw no difference with respect to timing of antihypertensive medication. Now we have a third study trying to shed some more light onto this question, which is the BEDMED trial. This was also a probe-designed trial, event initially targeting 406 primary outcomes. Now, due to COVID and reduced funding, they managed to get 336 primary outcomes, so it was maybe slightly underpowered, but the MAPEC trial, for example, only had 270 outcomes. It was done in Canada. Patients were recruited from primary care physicians or social media campaigns. It was a very simple study. The inclusion criteria was you had to have hypertension, you had to have at least one BP-lowering drug, and patients with night shift work were excluded, or palliative patients. Patients in the intervention group received their once-daily BP meds in the evening, and in the control group, they received their meds in the morning. As this was a randomized trial, the baseline characteristics are very similar. Just want to point out that the BP medication taken was, again, very similar between both groups. Now, the primary outcome, again, was a composite outcome of all-cause death, hospitalizations, emergency department visits for stroke, heart attack, or heart failure. And the secondary outcomes were each component, and there were also some safety outcomes. The median follow-up was 4.6 years, and only 3% were lost to follow-up or withdrew their consent. Now, this is a very interesting slide, the adherence to allocation. So in green, we can see the patients who took their medication as prescribed. In orange, the patients who did not take their medication as prescribed. And in green, the patients who took twice daily medication. And this wasn't randomized to once daily. So beta blockers, especially, a lot of patients took them twice daily, and the trialists left them like they were. And I think we can see that the evening allocation patients didn't take their meds just as much as the patients in the morning. And this was especially true for the diuretics, which I think is very reasonable. I don't know how many of you like to get up at night and go to the bathroom. Now, when we look at the primary outcome, we see absolutely no difference. So this is in line with the time trial. P-value of 0.70, and we had event rates which weren't that low in both groups. Looking at the secondary outcomes, I don't want to mention all of them, but as you can see here, they were all non-significant. Now, the authors thought, now these were young patients, maybe older patients have some kind of circadian rhythm and might profit from therapy in the evening. Same trial design, these were all patients on continuing care wards, so allocation to medication could easily be done by the treating nurses there. Intervention group, again, had their medication in the evening, and the control group had no change in BP medication, but generally in these continuing care wards, the medication was given in the morning anyways. We had the same primary outcomes, we had safety outcomes. Follow-up was shorter with 1.1 year due to much higher event rates in this old patient group, and we also had a very low loss to follow-up and withdrawal rate of 4%. We see the same picture. There was no difference in primary outcome in any of these two trials. Now, when looking at the secondary outcome, there was one outcome with a p-value of 0.02, which was formally statistically significant. It was all-cause unplanned hospitalizations, but I think this is rather a spurious result, and given the amount of subgroup analyses, we need to think about the fact that 0.02 is actually significant. So in summary, it seems safe to take your antihypertensive medication at any time. There seems to be no cardiovascular benefit from evening dosing. There's no evidence supporting this concept of chronotherapy. So the idea is basically to tell your patients, take your medication whenever you're least likely to forget it, because patient compliance is probably the most relevant issue. And now I want to talk about risk prediction. Now, LDL cholesterol, we all measure it, we all know about it, we all treat it. In primary prevention and secondary prevention, we have some strong evidence proving that it works with statins, with PCSK9 inhibitors. Then there's Lp(a). Now, this is a newer molecule. We have medication that effectively lower it by very large margins. Hard outcome data are still lacking, but I'm sure we'll get those at some point. And lastly, inflammation measured by high sensitivity CRP. We have a few trials, the CANTOS trial using canakinumab, the LODOKU trial using colchicine, that actually showed that reducing inflammation in these very high-risk patients improves outcomes. So now, Paul Rittger and colleagues looked at inflammation, cholesterol, Lp(a), and 30-year cardiovascular outcomes, which is almost unheard of, and they did this in initially healthy young women from the NIH Women's Health Study. So 1993, they took blood and analyzed these three biomarkers, and then prospectively followed up all these patients for 30 years. There was a primary MACE outcome of MI, coronary revasc, stroke, or death from cardiovascular causes. And obviously, since it was not randomized, they had to adjust everything for age and different competing risk factors. So what they did is they created quintiles. And in each quintile, they had the same amount of patients, but I think as you can appreciate here, other risk factors like hypertension, diabetes, and current smoking weren't the same in each quintile. And for example, for high sensitivity CRP, we have much higher risk factors in quintile 5 than quintile 1. They tried correcting for this in the analyses, but it wasn't exactly the same. Now, this is their main outcome. We see the adjusted hazard ratios. And what they did here is they compared the 5th quintile to the 1st quintile. And for all three biomarkers, they saw increased hazard ratios. Interestingly, the hazard ratios for high sensitivity CRP as a marker for inflammation were the most significant. But what the authors also show us, which is very interesting, are cumulative incidence curves. Now, until now, we always look at patients, we say, you're 5 to 10 year risk. We have the U-Prevent score. I don't know if you used it before, but we can enter all these data here and get a 10-year risk score. But here, we have 30-year risk scores. And I think you can appreciate that the risk spread increases significantly after these 5 to 10 years. Similarly for LDL cholesterol, 5 to 10 years, it doesn't seem that significant, but after 30 years, we have a much larger spread. And what's also interesting is that we look at LDL cholesterol and high sensitivity CRP. Patients in the highest CRP level seem to have the highest risk. Now, these were all adjusted for other risk factors: age, treatment, smoking, diabetes, blood pressure, kidney function, BMI. And then we have Lp(a), which is a bit different because the quintile 1 to 4 seem to be very, very similar with risk, but only patients in the highest quintile seem to confer a higher risk. Now, the authors also looked if these were independent of each other, and they looked at the joint effects. And I think what you can appreciate here is that if you have 2 risk factors, you're always on a higher risk than if you have 0 risk factors. And in fact, what the authors then did is looked at all 3 biomarkers together. And if you had elevated biomarkers for all 3, your hazard ratio after 30 years was statistically significantly higher than for the other groups. Now, this was an observational study, not an interventional study, but it still begs the question that we should maybe start thinking not just about 5 or 10-year risk, but also about lifetime risk. These are all modifiable risk factors that we can treat, 2 of which we have hard outcome data for that treatment improves outcomes, 1 of them probably soon. And these were all young women. Average age was 51, I believe, in whom at the older age, cardiovascular disease probably remains underdiagnosed and undertreated. So the question really is, should we screen universally not just for LDL, which we do now, Lp(a), it's starting to come out. We start doing that for most of our patients, but maybe also high sensitivity CRP. And with that, I'd like to conclude. Thank you very much.
Excellent presentation, Jan, and you picked 3 really important trials that are, relevant for clinical practice, I guess. When you were to put that into perspective, and I'm sure there are a lot of questions from the audience as well, when you put that into perspective, what's your take on the first trial regarding beta blockers post-myocardial infarction in clinical practice? Would you advise in patients with ejection fractions above 40% to stop it, to continue it? Or should we, look at this more in a personalized approach and saying, if blood pressure is well controlled, for instance, and if I'm not concerned that blood pressure rises and introduces then the risk factor to patients, is that something where you would say, okay, in those patients, stop it. If high blood pressure is an issue, hypertension is an issue, you should better continue it?
So I think that we have very little data in that subgroup between 40 and 50%. Now, the other trials all had ejection fraction over 50%, and there were 23% of patients only in this trial. Generally, when these patients come, they get a beta blocker, and I'd be very cautious in this patient population to stop the beta blocker. Now, if a patient comes to me, he has an ejection fraction of 42%, I see inferior scar, inferior wall motion abnormalities, probably a scar, I'd be very cautious to stop it. Now, regarding hypertension, I also think if this patient had hypertension before and was on beta blockers before, I'd probably not stop it, especially because we see that the quality of life seems not to be that greatly affected. So there probably aren't that many negative effects of beta blockers. And this introduction of beta blocker might be something where patients say, I don't like this. This is something where, my power goes down, my motivation goes down. But patients who are chronically treated with beta blockers, they have no more improvement when you stop them. So I think a lot of patients do get used to beta blockers. So in this population, I'd keep it probably.
Misha.
Excellent presentation, Jan. I was just wondering regarding the first study, again, with regards to quality of life. do you think we can be sure that quality of life is not different? Because that's against what I see in clinical practice. And I was wondering whether the EQ5D is the correct way to measure quality of life in these patients. Because when we think about the questions that the EQ5D poses, those are very general questions. What's your take on that?
Yeah, so I definitely agree. I mean, the EQ5D isn't a very in-depth analysis of quality of life. You know, there's a few short questions, and then you mark your general well-being on a scale. Now, this general well-being on a scale could be something that could be improved, but these patients knew they were off beta blocker therapy, and the scale was still the same. You know, so the debate is still out. I think if it's really, how shall I say, if there's really no difference, but I think there are patients who tolerate beta blockers, and I'm sure there's an individualized approach where there are certain patients who definitely don't tolerate beta blocker therapy. If they have an ejection fraction of 50% and no hypertension, I'd probably tell you, it's safe to stop it. But if their ejection fraction is 41%, they have a wall motion abnormality, they have hypertension which is difficult to control, I'd probably try to keep them on.
Philip?
So thank you for a very good presentation, even better than in London. I just wanted to comment on the design of the ABYSS trial, because I think it really biases towards the continuation group, because these are patients that have used beta blockers for 3 years, so they got used to it, they are positively selected for tolerating the beta blocker. And then also, we don't know the ejection fraction at the time of the myocardial infarction. I know it was an exclusion criteria that they had beta blocker as a heart failure treatment, but we don't know what the recovery was from the myocardial infarction to inclusion. And then also, the primary endpoint was driven by angina and coronary angiography, and it might be possible that patients continued beta blocker or even received beta blocker newly because of angina. So it was an anti-anginal therapy in some of those patients, and also it was not placebo-controlled. So if you as treating physician or cardiologist know that your patient has stopped beta blocker, now he has angina, then you send him to coronary angiograph. So I think there's several things that biases towards the continuation group. And I think it's a cleaner design and reduce EMI.
Yeah, no, I definitely agree. And what we also shouldn't forget, it's a non-inferiority design, so every patient that crosses over from the intention to treat to the protocol analysis basically favors crossing over on this non-inferiority margin. And like you said, it was soft endpoints driving this study. Patients were on chronic therapy, it wasn't acute therapy, but still I think the safety profile is still there. So if you have a patient in the certain ranges, probably not, but there's definitely a large proportion of patients who don't need the beta blocker therapy.
Obviously, the high CRP has the highest risk for long-term cardiovascular disease. How will you find, reach, and treat these young women at risk? I think they have an age where they are not interested in treating risk.
So these women were actually, the average age was 50 years. And at 50 years, maybe they start having interest in their cardiovascular life, and maybe it's also up to us to show these women in some form of social media campaigns that risk is there. We can measure risk, we can treat risk. Now, I think it's very important to remember that this is an observational study. It is not an interventional study. It is primary care, it is not secondary care. So even if we treat these women with statins, which also lower inflammation, as we know, high sensitivity CRP lowers by around 40% if we treat with high potency statins, but if this intervention also reduces risk, is the next question that I don't know if we will have an answer to that with these long-term outcome data, but we also know that statins are generally safe, they are safe in long term, and we know that the effect of statins improves the longer you take them. So I don't know how we will reach them, I don't know if we can reduce events significantly, but maybe that's something that we need to look at, like you said.
Jan, talking about the third study that you presented, I saw Paul Ritka presenting it, and I was very surprised to see that went into the New England Journal of Medicine, because as you nicely said, this is an observational study, long follow-up for sure, a lot of patients, but what's really new, right? What is adding to the existing evidence and I think, and that's something I discussed with Christian Müller earlier this morning, the Lp(a) story, there is something in which I think is sometimes overlooked, because we believe that there is a causal interaction between risk and Lp(a), and here you nicely showed it, only the 5th quintile had risk association, and this is, also pointing to a higher threshold probably when risk starts as compared to LDL cholesterol and as compared to other risk factors, including hypertension.
Yeah, so I definitely agree. I mean, the big question is, who do we even treat?
Yeah.
And at what cutoffs do we start treating? And at what risk cutoffs do we start treating? I mean, I think the American guidelines say a 10-year risk of 7.5%, correct me if I'm wrong, and then you should start a statin. There's new PREVENT guidelines out now with a different calculator, which changes everything a tiny bit, but I think for primary prevention, it's very difficult to have a certain cutoff where you say you profit, you don't profit. I think that's a discussion with a patient that we need to have, but I think Lp(a) is something that we can measure, and if they really have very highly elevated levels, which are also mentioned in our guidelines what the cutoff is, then it's probably worth it treating these aggressively.
At a certain threshold. Yeah. Marco.
Thank you, Jan. Great presentation. Again, also great discussion. Also, I would like to start from the 3rd study, but perhaps ask your opinion beyond that. What I would like to consult you about is the inflammation story. You show the data, which is nothing new, that there is a risk connected to the inflammation, the higher the worse. We have seen the data about canakinumab. The data is positive, yet we don't have the drug because the company said it's not profitable to go in the market.
Exactly.
We have seen the data about colchicine, which were labeled as class 2B, and this year, the 2024 CCS guidelines decided to upgrade to 2A, which is quite a jump. So that is the first question. Why, not why, what do you think about that jump? So 2A means that we probably should start treating the majority of CCS patients. Second comment, which is perhaps to me even more intriguing, we risk stratify patients based on degree of inflammation, but we give a drug, which is an anti-inflammatory drug, to everybody without measuring CRP. What is the missing link between these two observations?
So let me start with the first question. I think one major thing why it was upgraded is, we have FDA approval. Simple as that. And the studies are there. I mean, the colchicine studies, the Lodoku and Colcott study, they showed that there is a reduction in the primary endpoint, but I think that's the main driver, probably pretty, for the upgrade of this thing. And what is the link between cholesterol and inflammation? Now the question is there a link between cholesterol and inflammation? Maybe that's the question we need to ask. There was a discussion about if these two are correlated or completely independent of each other. And previous studies have shown correlation, other studies have shown no correlation. And Paul Rittke actually said that in their trial now, they found no correlation between these studies. So these are really two independent issues. But I don't know, these are observational studies. I think we need to remember that. And if treating these women at 50 with aspirin, colchicine, and maybe some new Lp(a) treating drug, something that we should, look at in the long term, because these are low-risk patients and they benefit. So the question also is, what about older patients, maybe men? Here in Switzerland, we have average age, what is it, I think 86 now or something like that. So if we look at them at 60 years old, should we screen all of them? Do they have even more benefit from this?
So it comes back to personalized medicine, right?
Yeah.
Where we are very poor at the moment. Jan, last question probably related to the second study that you presented, bedtime. And I think that really closes the book and turns a page into saying there is nothing behind chronotherapy. One Spanish group very actively and aggressively promoted this whole concept of saying you have to provide all antihypertensive medication at nighttime, because that is where the risk for strokes and major cardiovascular events is highest, particularly during the morning surge where sympathetic activity is highest. So provide all drugs at bedtime. And they pushed this hard. Now we have 2 randomized control trials, both of them indicating that there's absolutely no difference between the two. There was a meta-analysis presented in the same hotline session where bedtime was shown and discussed, also indicating that there is no difference between the 2 dosing and treatment regimens. And I think you said it too, non-adherence to medication is highest for all nighttime medication. So whenever you prescribe something at night, be sure that patients are taking it, and the likelihood that they don't is pretty high. So in summary, I think what you said is very correctly so. There is no difference, so you can treat either during day or during night, and consider patients' life and patients' attitude to medication and pharmacotherapy. When they can take medication at night and you have, for instance, a non-dipper that you want to treat, that's perfect. Possibly a patient that may benefit from such an approach, but there is no general rule and no general advice to treat all patients with bedtime medication and nighttime medication. Is that correct?
I couldn't agree more, and there's no more trials looking at this. So I think all trialists close their books on that one.
Okay. Any further questions on hypertension and bedtime? If that is not the case, thank you very much again, Jan. Christian, we're closing the first session, right? Out for lunch till 1 o'clock. See you again at 1 o'clock. Thank you very much.
Test, 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 Test. Das geht nicht mehr, oder? Test, Test, Test. Hallo? Hallo? Ne, ich habe hier es global ausgemacht. Warte mal schnell. Ja, das RP ist noch, aber ich habe global Mix ausgemacht. Weißt du? So, jetzt aber. Jetzt sind alle anderen ab, nur noch das Rednerpult-Mikro läuft. Und der ist auch leer. Da, das funktioniert auch. Tipptopp. Wunderbar. Soll ich mal mit dem Headset schnell darüber sitzen? Ja, einfach zum Testen, oder? Gut, Headset Nummer 1. Ich laufe mal schnell rum. Dann gucken wir mal, was hier passiert, wenn ich mich hier rübersetze. Ich spreche jetzt mal bewusst nur sehr, sehr leise und dann dürfte das hier eigentlich nicht mehr wirklich anziehen. So ein bisschen noch. Ja. Ja, aber das ist ja, also wenn ich jetzt in einer normalen Lautstärke, Gesprächslautstärke spreche, dann ist das laut genug, oder? Und da zieht halt gar nichts an. Ja, das war so eine Kombi aus Würfel, interner Feedback-Controller plus externes Headset und so, aber so ist es super.
1, 2. Herzlich willkommen. Mein Name ist Stefan Windecker. Es freut mich außerordentlich, Sie im Namen von Barbara Stelli aus Zürich und vor allem unserem Gastgeber Felix Mahfoud zu der Nachmittagsrunde zu begrüßen. Im ersten Teil werden wir uns den Herzklappenerkrankungen zuwenden, beziehungsweise den wichtigsten Präsentationen anlässlich des ESC. Und wie Sie vielleicht erfahren haben, wurde anlässlich des ESC das Lebenswerk von Alain Cribier gewürdigt. Sicherlich einer Persönlichkeit, die das Feld der Transkatheter-Herzklappenerkrankungen wie keine andere über die letzten 4 Dekaden geprägt hat, was zu einem der größten Paradigmenwechseln in der kardiovaskulären Medizin geführt hat. Und in diesem Zusammenhang freut es mich sehr, dass Thomas Nestelberger uns jetzt die wichtigsten Studien zum Thema Herzklappenerkrankungen zusammenfasst.
Vielen Dank, Stefan. Dear colleagues, dear gentlemen, and ladies, it's my great pleasure to give you an update about valvular studies presented at the ESC conference this year in London. When I looked through the program, it was pretty hard to decide where to go and where not to go, because there were so many trials published and presented in the hotline sessions and in the late-breaking science sessions. And we had 6 trials presented in the hotline sessions. One was about the continuation and interruption of oral anticoagulation during TAVR, a very important trial. Then, shall we perform PCI in patients undergoing TAVI or not? Another trial was comparing transcatheter versus surgical aortic valve replacement only in women. Another trial compared transcatheter edge-to-edge repair versus mitral valve surgery in patients with heart failure and secondary MR. Another trial compared edge-to-edge repair in heart failure patients versus medical therapy in moderate to severe MR and heart failure patients. And another trial looked into tricuspid repair with a clip in patients with severe TR versus medical therapy. All 6 of them were presented in hotline sessions. Here you have the name of the trials, and given the lack of time, I'm not able to present all of them. I would like to highlight, before I go into more detail, that 5 of them were investigator-initiated trials, so not sponsored by pharmacy companies, and 4 of them were simultaneously published in the New England Journal of Medicine. 2 of them are not published yet. I have chosen 3 of them to present, given the lack of time I have, but 2 of the other ones will be presented today in later sessions, in the women health sessions and the heart failure session, so we will hear those trials later on today. I would like to start with the popular post-TAVI trial. As I said before, it compared continuation versus interruption of oral anticoagulation in patients undergoing elective TAVI procedure. As we know that 1/3 of our patients undergoing TAVI have an indication for oral anticoagulation, mostly atrial fibrillation, and we know from some observational studies that it might be possible to continue it with a similar risk of major bleedings, but probably also with a lower risk of stroke. But we do not have a randomized trial for that, so we do not know actually what to do. Many centers stop oral anticoagulations for 1, 2, or 3 days, but there's no clear evidence for that. And the authors looked into that, and their primary objective was to investigate the safety and efficacy of continuation versus interruption of oral anticoagulation during TAVI. Their primary outcome at 30 days was cardiovascular mortality, stroke, myocardial infarction, major vascular complication, and major bleeding, based on the VAC3 criteria. Study population was patients undergoing TAVI, elective procedures, transfemoral or transsubclavian. They had to be on a NOAC therapy or warfarin therapy, and informed consent was necessary. And they excluded patients, of course, with mechanical prosthesis, intracardiac thrombus, or patients with a prior stroke or thromboembolism in the recent month before. Here we see what they did. So in the continuation group, you can see here, patients just continued their therapy. Even on the day of the procedure, they took it, and the patients in the interruption group, they stopped it either 2 days before. Dabigatran was stopped 3 or 4 days before, based on the kidney function, and warfarin or Macomar was stopped 5 days before. And in all patients, it was resumed then at 1 day, but this was not mandatory in the protocol, but in most patients, they did it like this. And there was no bridging performed with heparin. Here we see the power calculation. 858 patients are necessary to show non-inferiority with a power of 90%.
with an expected event rate of 13.5% in the continuation group versus 17.5% in the interruption group. And the margin they chose for non-inferiority was 4%. And if non-inferiority is satisfied, then they could also perform superiority testing. Here you see the flowchart of patients, one-to-one randomization. Only a few patients were not performed the procedure or withdrew their informed consent, and most patients were then analyzed. You see that the follow-up was performed at 30 days, and follow-up data were available in 100% of patients. Baseline characteristics: 81 years old, 1/3 female, atrial fibrillation in almost all of them, CHEST score 4.5. Several patients had a prior stroke, PAT, and half of patients had a kidney disease, as you can see here. Antithrombotic therapy was 82% were NOAC therapy, 18% was warfarin or Macoma, and 1/4 of patients had a reduced dose. And some patients also had a concomitant antiplatelet therapy, aspirin or Plavix, in about 11, 12, 13%. And adherence to the study protocol was pretty good in both groups, also comparable. Here's the primary outcome, and you see that the continuation group in red had an event rate of 16.5%, and the interruption group had a lower rate of 14.8%, and given that, the non-inferiority margin here was crossed, so it was not non-inferior. So they did not perform superiority testing, and it favors more the continuation, not the interruption of the anticoagulation therapy. When we look into the secondary outcomes, we see that this was mainly driven by bleeding complications. We see that major bleeding was comparable in both groups, about 10-11%, as we can see here, but the continuation group had much more minor bleedings, 21 versus only 13%, we can see here. Major vascular complications were comparable, hemorrhagic stroke comparable, and ischemic outcomes we can see here: cardiovascular death, ischemic stroke, myocardial infarction, systemic embolism was also comparable in both groups. So it was mainly driven by minor bleedings, 10% more in the continuation group. They also performed a subgroup analysis for this primary outcome, and you can see here that there's no clear benefit for continuation for one of the subgroups. We can see here that also patients with a prior stroke or high CHEST score did not benefit if we performed continuation. Interruption was better in those patients with a high frailty score. My take-home message on that study is that continuation was not found to be non-inferior compared to the interruption of oral anticoagulation during TAVI. The incidence of thromboembolic events appeared to be similar in both groups, but we saw more bleeding complications in the continuation group, and oral anticoagulation therapy should therefore not be continued during TAVI, so we should stop it. And what I was also thinking when I looked into the data was that the major bleeding rate of 10% was kind of high, so we should also think about how we can better prevent those bleeding complications in these patients undergoing elective TAVI procedures. With that slide, I would start the second trial. I would like to show you again a very important trial looking into PCI in patients undergoing TAVI in addition. So what they looked into is our patients having coronary artery disease and a severe aortic stenosis. Again, it was an investigator-initiated trial in the Nordic countries, 16 centers, as we can see here. Again, funded mostly by the Danish Heart Foundation in Boston, but investigator-initiated. And here are the inclusion criteria: severe aortic stenosis, scheduled for elective TAVI procedure, and a coronary artery disease. At least one stenosis in a bigger vessel with a diameter of at least 90%, so high-grade stenosis, or an FFR of 0.8 or less. Exclusion criteria, mostly common criteria, but also ACS was excluded and left main stenosis was excluded in this cohort. The endpoint was all-cause mortality, myocardial infarction, and revascularization. And they didn't say that it is 1 year or at 5 years. They said that they will include the last patient needs a follow-up of at least 1 year to have a median follow-up of 2 years, and patients were followed up to a maximum of 5 years. So their power calculation was performed on event rate at 2 years. Primary endpoint in the conservative group was 35%, the assumption of it. In the PCI group, 23%, which causes a relative risk reduction of 34%, and you need 452 patients with a power of 80% to show superiority. Here we see the flowchart, one-to-one randomization, TAVI versus TAVI and PCI. Most patients underwent procedures in both groups, as you can see here. And here the patient characteristics. We see again 81-year-old patient, 1/3 female, SDS score about 3, so low-risk cohort, ejection fraction normal, diabetes in some of them, oral anticoagulation in 1/3 of patients. Coronary lesions, when we look at them, we see that the vast majority of patients had a stenosis of more than 90%. The others had a FFR of less than 0.8. Multivessel disease was only not very common, only in 1/5 of patients, and the syntax score of those patients were about 9, so actually kind of low. And LAD lesions were found in about 60% of patients. PCI was usually performed in the vast majority of patients before TAVR. This was suggested in the protocol, but it was not mandatory. In some patients, it was performed after or during TAVI, and complete revascularization was achieved in 90% of patients. Here we see the primary endpoint. Remember, median follow-up was 2 years, but here it's up to 5 years in some patients, and we see that it was statistically significant hazard ratio of 0.71 in favor of complete revascularization, in favor of PCI, 26 versus 36% event rate. And when we look into the secondary endpoint, we see here in B that death from any cause was similar, but it was mainly driven by myocardial infarction or urgent revascularization to result in this primary endpoint difference. When we look into subgroups, and I think also here is very important to highlight that especially those with a high-grade lesion, 90% or more benefited from a PCI versus conservative management. In all other subgroups, they found no differences. So my take-home messages again, or the summary of the study, is that in patients with stable coronary artery disease, so acute coronary syndrome was excluded, undergoing TAVI, PCI was associated with a lower incidence of this composite endpoint, mortality, myocardial infarction, and urgent revascularization at a median follow-up of 2 years. In my mind, I think it's very important to highlight that the lesion must be relevant, 90% or more. Current guidelines recommend 70% and no FFR measurement. And it's unclear still whether PCI should be performed before or after TAVI, but future trial will answer that question. And given the margin, when you remember the confidence interval was from 0.5 to 0.99, I also question, was the sample size large enough to change the guidelines, or do we need larger trials first? And one trial which is currently undergoing is the complete TAVR trial with 4,000 patients, 2,000 undergoing complete revascularization after TAVI versus medical therapy in the other 2,000. And in a few years, we will hopefully have this answer from that trial. The third study I would present to you is the Matterhorn trial. It's a German study. They called it Matterhorn. I don't know why. It was performed in 16 centers in Germany. And what they did is they looked into patients with secondary MR, heart failure patients. They had to fulfill at least 2 of the echo criteria or heart failure hospitalizations within the last 2 months. They had to have an ejection fraction of more than 20%. And the heart team had to say either edge-to-edge repair or surgical mitral valve repair or replacement is technically possible. And the patients have to be symptomatic and VHA score of at least 2 despite medical therapy, perfect medical therapy. And their endpoint was at 1 year, death, heart failure, rehospitalization, mitral re-intervention, LVAD implantation, or stroke, the composite of it. It was a one-to-one randomization. Here we see their power calculation. They assumed a primary endpoint rate of 35%. Again, a non-inferiority trial. They have chosen a margin of 17.5%, so much more than in the first study I showed you. And this resulted then in a sample size of 180 patients. And accounting for dropouts, they recruited 210 patients, 105 in each group. Here are the baseline characteristics. Remember, in the TAVI trials, we had an age of 81. Here we have a much younger cohort, 70 years old. More females, probably a bit more than 1/3. Many of them had coronary artery disease, atrial fibrillation in almost half of them. But you see the SDS score is about 2, so kind of low compared to other trials, and patients were symptomatic. Most of them had NYHA 3 or 4, as we can see here. Procedural characteristics in the interventional group. Most patients received a MitraClip generation 3 or 4, the newer ones. We see the procedural success with an MR grade less than 2 or 2 was achieved in 96% of patients, so very effective treatment. Most patients had 1 device or 2 devices. In-hospital death was 1%, very good. In-hospital mitral valve surgery was about 3%. Detachment of the clip was 1%, and there was no effusion or exercise complication in the interventional group. Let's look to the surgical group, and here we see also a very high rate of procedural success. 99% of patients had no relevant MR grade of more than 2. We see that repair was only performed in 72% of patients, replacement in 28%. So it was based on the surgeon to decide whether to repair or replace the valve. Concomitant atrial fibrillation was only performed in 14% of patients. Remember, 50 had atrial fibrillation, 50%, and concomitant tricuspid repair was performed in 10% of patients. And we see a kind of high in-hospital mortality rate of 4.3%. Redo surgery was performed in 8.5% during the hospital stay, the first hospital stay, and in-hospital redo mitral valve surgery was performed in 1% of patients. And here we see the primary endpoint. After 1 year, we had an event rate of 22% in the surgical group for this combined endpoint, and only 17% in the interventional group. And the p-value for non-inferiority was positive, but not for superiority. Very interesting findings. They also looked into the primary safety endpoint at 30 days, and here this was then a combination of death, major bleeding, stroke, but also wound infections, mechanical ventilation for more than 48 hours, endocarditis, and a couple of others. And you see that the rate in the surgical group was much, much higher compared to the interventional group. Secondary endpoints, when we look at MR recurrence, we see that it was similar when we look just grade 2 or less. Of course, the surgical group had much more often no MR at 1 year compared to the TEER group. When we look at quality of life, both groups had an improvement in quality of life, a bit more in the TEER group, as we can see here. Hospital stay was shorter in the TEER group compared to surgical group, and the ICU stay as well. And the NYHA functional class improved in both groups, very similar as we can see here. My take-home message on that trial is that we can now say, or this is what the authors concluded, that among heart failure patients with secondary MR and heart failure, TEER was non-inferior to mitral valve surgery. TEER showed also a favorable safety profile and clinical improvement similar to surgery. The wide margin is questionable in my mind. 75% is of course in favor for a non-inferiority finding, but we have to keep in mind that TEER was better, so even with a lower margin it would still have been better. But what I also question, and we can discuss later, is what was the treatment of care in the surgical group. There was a very high rate of replacement. Why? There was a rate of stroke of 4%, a reoperation rate of 8.5%, and atrial fibrillation ablation was only performed in 25% of patients. So we can discuss that later if this was standard of care in the surgical arm. Another trial which is undergoing at the moment is the Repair MR trial, similar cohort, this time primary MR, and they will do it in 650 patients and hopefully will give us more answers on that. And with that, I would conclude and thank you for your attention and looking forward to the discussion.
Thank you very much for this concise summary of certainly practicing influence randomized clinical trials. I'm sure there will be many questions, and maybe I kick off with notion 3. I think notion 3 was a surprise for many due to the impression that management of chronic coronary syndromes may not be meaningfully impacted by PCI other than symptom improvement. Yet, in Notion 3, in a patient population with mean age above 80, that is in life expectancy of perhaps only 5 years, there's a significant advantage. And as you pointed out, the large benefit was with a 50% relative risk reduction in myocardial infarction, followed by urgent revascularization. But there was also a 15% relative risk estimate as it relates to mortality. So really every of the major individual endpoints trended into the direction in favor of PCI. And that obviously triggers the question whether we need to change our attitude towards the treatment algorithm incorporating coronary artery disease into the decision making when patients are considered for aortic replacement therapy. My first question to you relates to your conservative interpretation. Anybody only with 90% stenosis should be considered. Are you really certain that is, if a patient with an 80 or 75% stenosis presents to you, would you not have a conversation about this? And in that context, maybe you can also address that there were no differences as it relates to symptoms between both groups after the treatment. That would be my first question.
Yeah, it's a very good question. I agree with you. I discussed this in our clinic with the patient if there was coronary artery disease diagnosed. But it's usually an incidental finding. So we didn't look for coronary artery disease. We underwent a TAVI workup in these patients. We performed a coronary angiogram. And I always ask the patient, how do you feel? Is it only the shortness of breath, mostly from the valve caused, or is there also some angina symptoms? And if a patient has angina symptoms, I more likely go for PCI or revascularization in the patient, especially if it's only a 70 or even a 50% lesion in a very proximal part of the arteries. Then I probably more likely also do that. But if it's like a side branch of the side branch in a very small diameter, then I would not do it. And the other question for me is then when to do it. So probably we perform the TAVI first, see if the patient is improving a month later or so. And if there are ongoing symptoms, dyspnea or chest pain, then probably we can do it then. Probably there's no benefit to do it before. We don't know that yet, if it's better to do it before or after for symptom improvement, but hopefully we'll have that answer soon. Yeah.
Yeah, I'm glad that you touch upon this issue because I think the timing indeed is an important one. Now in Notion 3, 2/3 of patients were actually treated prior, but I agree with you that probably a cautionary approach that is to treat the main lesion first, followed by the PCI, may be a valuable alternative. And it's important to note that in complete TAVI, that will be the default approach. Marco?
Also, I would like to comment in the Notion 3 space. If there is something which did not go in the right direction in favor of PCI is any bleeding. And I did not get the understanding whether that bleeding signal was coming from a pre-procedure excess of complication or long-term. Most likely both, because long-term unfortunately could have also been ascribed to the fact that in a historical way, patients with PCI received 6 months of DAPT. Secondly, what speaks in favor of doing PCI after the procedure is the fact that you can do TAVI, the procedure is TAVI, after TAVI without a DAPT in place, which we know from all studies is not a good idea. So I would like you to comment upon this.
Yeah, I agree with you. I didn't mention that. There was a higher bleeding rate in those patients undergoing PCI. We don't know, was it happening during the PCI? Was it happening during the TAVI procedure? We don't know that. They didn't mention that. But I think that's a very good point because if you perform it before, you are on dual antiplatelet therapy and then you do a large bore access on the patient, probably just a few days after the PCI. So probably that's the reason why they had higher bleeding rates in that group. And we also know that from some registries, large registries, which showed that if you perform it before, you have no benefit in terms of ischemic outcomes or less MI, or also the TAVI was not more unsafe to perform with high-grade lesions, but they also found that there was more often a bleeding complication. So probably it's better to do it after. what they showed, I didn't show that slide, is that patients undergoing TAVR without revascularization, they had not more complications during the TAVI procedure. There was not more arrhythmias or CPR necessary or adrenaline or whatever. So it was very safe to do it with these high-grade lesions, it seems.
But Marco, I think you would agree that the standard duration would be rather a month in 80-year-old population. Perhaps one more question related to notion 3, projecting ourselves to the expansion of the indications to younger patients. Partner 3, Evolute Low Risk, we're already mean age of 70, but also considering surgery as an alternative. So how do we deal with relevant coronary artery disease in younger patients, and how do we take into consideration the alternative option that is surgical aortic valve replacement and combined with CABG?
Yeah, that's a very good point. I think this cohort, the patients were 81 years old, but I think in the future we will treat more often younger patients. And in those patients, probably a different story. We already saw the difference in these older patients. So probably in a 90-year-old, you do not need to do it. But if the patient is 70, it's very, very likely that this coronary artery disease he already had at that time will progress to a more significant lesion or probably also cause an acute myocardial infarction. So I think we should address that, and we should be more liberal in younger patients to treat coronary artery disease.
Along these lines, Thomas, I was a little surprised. So first, I was surprised to see Notion being positive. I didn't expect it. I thought chronic coronary syndrome in TAVI is no different to chronic coronary syndrome without TAVI. Obviously, that's wrong. So is that related to a higher risk in that patient population being present? That's something we can discuss probably too. But my question relates to the severity of stenosis and the assessment of the severity of the stenosis, right? So you showed that they used 90% stenosis, diameter of stenosis, but they also used FFR with a cutoff of 0.8, which is not really, or has never been prospectively evaluated in larger studies in patients with a severe aortic stenosis. So the question is, 2/3 of the patients received revascularization and assessment of stenosis severity prior to TAVI. What does FFR really tell us in these patients?
That's a good point. They had 223 patients in the PCI group, and 190 of them or so had a lesion more than 90%. So only a few more, 30, 40 patients more, had then a FFR of less than 0.8. It's questionable if it's accurate like in other patients without severe aortic stenosis. We know some studies that the FFR changes if you do it before and after TAVI. Yeah? So we do not know is the cutoff 0.8 the correct cutoff. I think this is also something we have to investigate to find the correct cutoff. Probably we need a different one. Yeah?
Maybe just a short additional question. We are speaking about doing PCI before or after TAVI. What do you think about combined procedures? Do you do it at your center? Is it logistical, challenging situation mostly?
I did it a few times, but to be honest, I do not like to do it. It makes the procedure longer. It gives you a higher risk of contrast, a higher risk of complications, I think. So usually I like to do it before or after. And years ago, we did it always before, the day before, but we changed our practice now and we do it in most patients later on.
Patients may request at the same time. Michael, yeah.
Some do, yeah.
Regarding the first study that you showed, interrupted versus uninterrupted anticoagulation during TAVI. And I was wondering if you have a patient on uninterrupted anticoagulation and you have a complication, it's conceivable that these rare cases where you have a complication don't pop up in the statistics, but this rare patient has a more severe complication on uninterrupted oral anticoagulation. Did they show anything about the management of complications, such as use of antidotes?
They only showed in their tables that patients received 7,500 units of heparin during the procedure. Most of them received also protamine at the end of the procedure. So this was standard of care in their cohort, but they didn't say anything about how they treated the complications. But it was mainly driven by the minor bleedings, not by the major bleedings, but still there was a signal that continuation was associated with a higher risk of any vascular complication or bleeding. I think I'm surprised about that finding. I thought it would be okay to continue it, because we had a few patients who forgot to stop it and we just performed the TAVI. And in most patients, we did not have any bleeding, to be honest, because I was always more afraid of the stroke. Or in those patients, you stop it a few days after TAVI, the patients are just lying in the bed for several hours, for one day probably. I was always afraid about this more than a bleeding, because a bleeding I can treat more easily than a stroke, for example. But surprisingly, it was the other way around. So stroke was similar in both groups, and bleeding was more common in the continuation group. Yeah.
So certainly also a clinically relevant study as for EF ablation procedures. PCI we would continue, but this is one with large bore catheters where it probably makes a difference. Maybe just as a last point of discussion, returning to Matterhorn, I think it's important to note that the Matterhorn population was completely different from COAPT and ReShape. EF was 10% higher, mortality was much lower. It was much more analogous to the CTSN network surgical study comparing repair versus replacement. And in that context, I was surprised that actually replacement was performed in 1/4 of patients. And I also see surgeons here in the audience. Maybe we can discuss a little bit, is there a change in attitude away from repair, rather going to replacement, even in this patient population, because that would trigger in me the question, what are really the long-term results where you need to be concerned about valve degeneration?
Now you have motivated the surgeons to reply.
Yes, Roman Gottardi, Freiburg. I think it's functional MR. And we know that if the tenting height of the leaflet is above 11 millimeters, we will have a high probability of recurring mitral insufficiency. So I think in functional patients, 25% of replacement is not a bad result. We can change this further if we do some subvalvular techniques like sling around the papillary muscles or leaflet enlargement. But I think in this patient cohort, 25% of replacement is not bad, and I think we have to look at the long-term results. How many of those patients stay patent? And I think with the valve, we have the best option that the valve stays patent, compared to a repair where we have a recurring insufficiency, especially in functional. Completely different to primary, where we always need to look to repair the valve. But for functional, if the tenting height is above 11 millimeters, I think it's more than justified to replace the valve.
If there are no further questions, Thomas, thank you very much again.
Thank you.
We're continuing with the next presentation, and it's my pleasure to ask Marco Vagimidi to talk about acute coronary syndrome and chronic coronary syndrome. What were the most relevant studies to be presented? Marco, great to have you with us.
Thank you, Philip. Thank you, Barbara. Thank you, Stefan. And also, most importantly, thank you, Christian, for getting this meeting, as always, beautifully organized this year as well. These are the studies that I plan to discuss with you. I would like to make an extra thanks to the previous speaker, because I can go basically jumping two of them, ABYSS and Notion 3, because they have already been discussed. And that would ideally save more time for our discussion. So then I'm left over with these three studies. One is Occupy. It's an important study because it's a déjà vu. It's something that is already known, but it is a confirmation of what is known, and most likely something that is not always done in routine practice, which is the use of intravascular imaging modalities to guide the procedure, both before and after intervention, in patients who undergo so-called complex PCI. The study is about, I let angiography tell me what I should do and which result should I accept, or I rather image the vessel before and after, and perhaps even during, with a specific imaging modality, which is optimal coherence tomography, to understand where the stent should be placed, and most importantly, how the study should be placed. Apparently, the study focused on complex PCI, complex lesion. In fact, it's not only lesion, it's also patient, because ACS patient, STEMI, non-STEMI, was part of the inclusion criteria, plus a subset of patients whom, in fact, the lesion was particularly long, particularly complex because of bifurcation, or difficult to be treated because of calcification, whereby the complexity was justified by the lesion per se. The study was a superiority study, planned as such, and in fact shown as such. At 1 year time frame, there is a quite impressive, significant, almost 40% risk reduction in favor of the imaging group. Image brings something into the picture if imaging is interpreted and performed well, which is basically the second KM plot which you have there, not because you use OCT that you can improve outcome. You improve outcome if you do a better job in the way the stent is placed and expanded, and in fact if you achieve predefined OCT criteria, that's where the outcome improvement comes from. In this study, which is relatively small, the advantage does not come from mortality, which is actually an endpoint which has been shown to be improved by imaging 1 year ago by Greg Stone in a meta-analysis at ESC. But in this case, it's improved by ischemia, target vessel, revascularization, and myocardial infarction, and numerically also stent thrombosis. So yes, we should force ourselves as interventional cardiologists, and perhaps even more so as non-interventional cardiology, to expect and wait for this imaging modality to be implemented routinely in the cath lab. Seniorita is a completely different question. It's a question which has been asked many times before. Patient with non-STEMI, should this patient be treated invasively or conservatively? We have many studies in that field. The answer is yes, otherwise we would not do so in current practice. But of course, in the elderly patient population, that specific question has never been asked, and that's what Seniorita is about. Only patients who were greater than 75 years old were eligible to get into the study. Not particularly high risk, simply non-STEMI being fulfilled. The study was designed as a superiority study with perhaps some optimistic assumption, which were at the end of the day not met in this study with respect to the primary endpoint, which was selected, which was basically death and myocardial infarction. Death did not actually speak in favor of an invasive approach. As you see there, it's basically pretty much flat. Yet the second non-fatal component of the primary endpoint was significantly reduced in favor of an interventional procedure already few, I would say, weeks, if not months after randomization, and this benefit basically was kept unchanged until the end of follow-up. And you see, of course, the MI benefit came also together with the coronary vascularization benefit. Taking into account that these patients were slightly selected, only 25% of eligible patients got into the study, and as always in these kind of studies, there is some degree of crossover in the conservative group, which allows clinicians to, of course, offer an interventional procedure in patients who cannot be stabilized medically. A very important question has been asked by the EPIC CAD study coming from Korea. The question is whether in patients who have an indication to oral anticoagulation and at the same time also concomitant coronary artery disease, whether 6 to 12 months after an PCI and or an acute coronary syndrome, respectively, patients should be better treated with dual antithrombotic therapy approach, meaning antiplatelet therapy, either aspirin or a P2Y12 inhibitor, and edoxaban in this study, or edoxaban monotherapy. Now, the study showed very clearly that the answer is monotherapy is the way to go, and mainly, if not entirely in this study, driven by bleeding, including major bleeding complication. Now, in this study, roughly 1,000 patients were included, and of course, the study is per se underpowered to answer the question about rarer endpoints such as MI and stroke. However, I had the privilege to comment upon this study, so I could not resist the temptation to make a meta-analysis on what is available there. We have today 5 studies, roughly 6,000 patients, which are basically delivering the message which is delivered by the single study per se. There is just a reduction in major bleeding, any bleeding, to embrace a single antithrombotic therapy, and there is apparently no penalty to pay with respect to fatal or non-fatal ischemic or cerebrovascular events. So the question is, why dual in 2024? Acknowledging that the majority of your patients probably are still on dual now, and that's of course a challenge for the discussion. If monotherapy is the way to go, in Matrix 2, Stefan and I, together with many other investigators, including Basel, Switzerland, and many others outside Switzerland, we are actually taking the concept of monotherapy to an extreme, because we think that monotherapy is the way to go from the get-go, and in fact the patient will stay on P2 or 12 minutes of monotherapy for 1 month, and DOAC monotherapy from day 31 onwards. Now, Sydney 4 was by far, I was discussing that with Christian, the highlight of ESC. I'm joking, I was presenting this study, but it's pretty much the same concept. We are over-treating our patients, and that is the leitmotif which is more and more coming through the studies. We pulled together all studies which were investigating monotherapy from few weeks up to maximum 3 months onwards with ticagrelor monotherapy or continuation with the APT for 1 year, which is basically what the guidelines still today recommend, unfortunately and mistakenly, in patients with acute coronary syndrome. We selected, of course, the phase where the gradient was there in between one therapy versus two, not the noise, which is the DPT common to both study groups. We put together 24,000 patients, and basically we see no advantage for dual antithrombotic therapy as compared to single antithrombotic therapy, at least with respect to this specific P2Y12 inhibitor. There is a huge reduction in bleeding complication if you embrace one drug instead of two. And in fact, in this study, pay attention to it, there is a mortality benefit of having one medication on board instead of two, which is a benefit which is coming all the way. The more you prolong the APT, the more you do the mistake, the more the patient will bleed, and the more the patient will also die. The question is whether these results are conclusive, and we found the difference in MACE, it's conclusive, the difference in bleeding is conclusive. There is still room to discussing the mortality benefit, which is, however, not futile, so which is worth being investigated. And ACS patient, basically, the results are even stronger. So think about prolonging the APT beyond few months, even in ACS patient, because that does not seem to be what you should be doing in 2024. And interestingly, we speak a lot about sex, gender differences. The female patients were the one driving the mortality benefit in this analysis. Very quickly, a bit more technical, yet interesting. You probably know that there is a sort of research of balloons instead of stents. These balloons are now medicated, yet still balloon. There is no prosthesis left behind. This is probably one study which is questioning this approach. In this study, once the lesion was successfully dilated, patients were randomized to drug-eluting balloon versus default second-generation stent implantation. Study was meant to show non-inferiority, which was actually not shown. The drug-eluting balloon was really inferior. Numerically, also with respect to mortality, which was surprisingly not explained by NMI difference. Actually, there was no difference in target vessel myocardial infarction, yet difference in revasc and ischemia-driven revasc in disfavor of the balloon technology. So perhaps the future will be a sort of an hybrid approach, which is the last study I'm going to present you, which is this Infinity Sweetheart coming from Sweden. Beauty that this was an independent study, yet specifically with this hybrid technology. There was some metallic component of the stent which are permanent. These are not going to leave the vessel. It's a permanent caging, pretty much what we do with the second-generation drug-eluting stent. But there is also a reabsorbable component in the stent which stays there for 6 months and then goes away. So in a way, partially uncaging the vessel down the road. The device is dynamics by adapter, it's called, together compared with the Onyx stent, which is one of the currently available newer generation DS. the non-inferiority was met for target lesion vascularization, and interestingly, high hypothesis generating, not more than this, but from 6 months onwards, when one device starts to leave the vessel away, you see that there is apparently a benefit with respect to this approach as compared to a permanent metallic stent implantation. With that, I thank you, and I'm very happy to discuss the study with you.
Thank you, Marco, for this brilliant overview of very interesting trials in the field of interventional cardiology. I'm sure there are a lot of questions and important issues we can discuss because it's important for our patients. Maybe I just start with one question I have regarding dual antiplatelet therapy. I completely agree with you that maybe we are overdoing it a little bit and we are focusing too much on ischemic complications or in fear of stent thrombosis. How do you personally do it when we have a patient in the cath lab? How do you assess the bleeding risk? How do you calculate scores? And at which point in time do you decide about the type and the duration of dual antiplatelet therapy?
Thank you, Barbara. So I think the moment in which you treat the patient, you should already have a plan with respect to how that patient should be treated with respect to DAPT or antiplatelet duration. Also acknowledging that that decision is not written in the stone, should be updated and continuously change over time. But if you fail to do so, even to begin with at PCI, that patient will be mistreated. That is why I think we should, as an interventional cardiologist, make a provision. That provision on DAPT or single antiplatelet therapy should, of course, be in a way confirmed, double-checked, and if needed, even modified by non-interventional cardiology, but that is the way it should be done. We should come together. With respect to the first part of your question, how do we assess the risk? I normally use precise DPT for the bleeding risk, but also some modification of the HBR ARC criteria, which are very easy to be remembered. For example, the need for oral anticoagulation is already labeling the patient at high risk. Age, of course, is something that should raise your flag. But of course, the integration of more difficult parameters, such as, for example, creatinine clearance, that requires the production of score, which I don't think you should routinely calculate, but at least at the beginning you should do it as more as you can to train yourself on how the bleeding risk should be done. So to me, the concept is not you should calculate the score every time you see a patient. Probably that would be for 6 months, for 3 months, to make yourself acquainted with that quantification. You as a clinician probably are able to do so without formal calculation. And the ischemic risk, apparently we are getting a bit more behind there, but I would say the lesion complexity is one driver, the acute presentation is the other one. I would make it very simple. Then I'm going to close with that by saying you would start from the bleeding risk. If that is high, you can stop calculating the ischemic risk because the bleeding risk should dominate the decision making. If bleeding risk is low, there is room for ischemic risk assessment. That is the way I do it.
And then you reassess it after 3 months or after 1 year, depending on the ischemic or bleeding events you had in the meantime.
Yeah, I always say 1 to 3 months maximum of DPT, and then is monotherapy. That is what I do.
Okay.
Yeah.
Further questions from the audience? Yeah.
Excellent presentation. Firework as usual, Marco. My question is toward edoxaban monotherapy in AF patients 1 year post-PCI. And so the one situation where the question still comes up is in post-CABG patients. Do you think even there the books are closed? Because in the studies, usually there are only a minority of post-CABG patients. And that's sometimes a question that comes up together with the surgeons.
It's a great comment. It's fair to say that in none of these 5 studies, apart from one, which is MASTER DPT, it's a PCI pure study. In all the others were CAD and AFib concomitant patients, mainly treated with PCI, but there is almost in all of them a subset of patients who underwent CABG. I would say that even in post-CABG studies, I would see the rationale for having a long-term antiplatelet therapy concomitant. I don't think it's a very sound one. The stent is not in place. There is no evidence that any of the bypass conduit can be affected by concomitant antiplatelet therapy. Actually, we have had studies on that respect, and they've always been negative. So to me, the patient should stay on OAC monotherapy, perhaps very shortly after CABG.
If I may follow up, so if you have put the patient on your favorite antiplatelet monotherapy that worked so well in your study for a year, or what do you then do for the long-term therapy? You stay off-label on this, your favorite antiplatelet for lifelong, or you go back to one of the old or perhaps better established antiplatelets?
This is a great comment, and actually that gives me and together with the moderators the chance to discuss the new CCS guidelines, which are already answering perhaps your question, because for the very first time, single antiplatelet therapy beyond 1 year is given with a similar class 1 indication with either aspirin or a P2Y12 inhibitor, which is a premiere that has never been documented before. And in fact, that comes from studies where long-term treatment with aspirin or a P2Y12 inhibitor has been compared. And in fact, there were advantages for the P2Y12 inhibitor. So what do I do with my patients after 1 year? I continue the P2Y12 inhibitor. I rarely do with 90 milligram ticagrelor. I always downscale ticagrelor to 60, or perhaps clopidogrel is also a very good idea, which I'm doing more and more, especially beyond 1 year follow-up.
Maybe I just start with some comment on Sydney 4 as the concept of P2Y12 potent monotherapy. And I think it's important to recognize what Marco pointed out is that there's non-inferiority in MACE, which is conclusive. There's superiority as it relates to bleeding, which is conclusive. And the only element that remains partially unresolved is the mortality question. But just to put things in perspective, our paradigm as it relates to patients with atrial fibrillation based on Augustus, Redual, and 2 other studies, in total of 4, were just based on a win in bleeding. None of those studies, and also the synthesis is not conclusive as it relates to mortality. I don't know, Marco, whether you want to comment on this. I just want to highlight once more why Sydney 4 is so important.
No, I think you said it beautifully. I cannot add much on what you said. I think this residual uncertainty with respect to MACE is not there any longer, because there is not only no difference in MACE, but if you take the scientific approach, you look at the upper limit of the 95% confidence interval, meaning let's assume things can go much worse than what went in the studies. The upper limit is 106, basically completely ruling out that there is an excess of MACE with monotherapy. There is a 50% reduction in bleeding, even if the mortality is not definitive, but there is no rationale for extending the EPT beyond 3 months in 2024. So every time you do that, you are probably doing a mistake, which is a very strong statement, but I'm doing that on purpose to make you think.
So, thanks for pointing out. Please join us on Matrix 2 to answer the questions for EVFib. Now, I want to come back to the first study, and that is the issue of intracoronary imaging. I think there is cumulative evidence clearly indicating that intracoronary imaging should be performed, yet in clinical practice it remains largely underutilized. And my question is twofold. The first one, what do you think is the mechanism as to where intracoronary imaging impacts the outcome, both, let's say, on a lesion level, also as it relates perhaps to the other remaining limitation of PCI, complete revascularization? That would be my first question. I follow then with the second part on.
This is a great comment. So I would say you're completely right. It's completely underutilized. Probably there are multiple reasons for that. First, it's time consuming. It is rewarded from an economical standpoint, at least in this country, which is good, but also needs to be interpreted properly, and it requires more time. So an easy procedure could become much more complicated, a lengthy procedure, because you are using imaging, and that's something we need to get acquainted with. So if you're working in a busy lab and you are scheduling 10 procedures a day, those 10 procedures may not be accomplished with the 10 times intravascular imaging guidance. That is a reality. So we would probably need to start thinking differently because of that possibility. Why does that make the difference? I honestly think more on the way the lesion is treated more than this lesion selection. I don't think, that's my personal opinion, of course, it's a complete versus incomplete revasc story. More what you should be doing before implanting the stent and most importantly after implanting the stent. If you are using a lot of imaging, you know when you should not implant the stent, if there is too much calcium that you have not broken down, and if that context you implant a stent, that stent unfortunately will never be properly expanded afterwards. So it's both when time has arrived to implant the stent and what should be done to optimize the stent implantation, which is an irreversible thing. If you do it badly once, that mistake will carry it over for the life of that patient.
And the second part of my question is, purists of evidence-based medicine would say the largest benefit comes from intravascular ultrasound rather than OCT, whereas I think in clinical practice we see much more in terms of detail with OCT. Do you want to comment on this, on the choice between the two?
Thank you, Stefan. Yes, I am perhaps getting old in answering this, but I tend to agree with you indirectly. I'm not a big OCT fan, I'm a big IVUS fan. And I very rarely use OCT because I am annoyed by the need of contrast with OCT. Realizing that perhaps the newer generation would use the contrast differently. They avoid doing angio, they do angio while OCT, so they spare contrast, but I am an old dinosaur and I much prefer IVUS, and I'm basically doing 99% of my procedure IVUS guided more than OCT guided. Also because IVUS gives you some extra information which OCT doesn't, meaning the adventitia. So you know how much aggressive you can be in further expanding the stent, not just optimizing the lumen, which is what OCT gives you.
Marco, I have a cognitive conflict and I need your help. Senior Rita, high-risk patient population, presenting with NSTEMI, acute coronary syndrome, no benefit of revascularization. We take notion 3, which we just discussed, and saw that in an elderly patient population at risk, but in chronic coronary syndrome, PCI was favorable as compared to no PCI. So how do you translate that into clinical practice? What is your which consequences are you rendering on senior Rita? And what do you think, how will guidelines react on the outcomes of the study?
This is a very difficult question, but an important one. Thank you for asking this. I would say that there are at least 2 different perspectives I would use to integrate these apparently discrepant findings. First is the primary endpoint selection. Second, the follow-up. Notion 3 shows a surprising benefit to me as well. I was expecting that study to be completely negative. But then the more I look into Notion 3, the more I look into the y-axis and say, it's 5 years, it's 5 years, it's 5 years, it's not 6 months. So the benefit is there, most likely the benefit comes later. Even the ischemia study, which is claimed by everybody to be a negative, well, it's negative at 3 years follow-up, but then at 4 and 5, it starts completely to change. There is a price to pay peri-procedurally if you do an invasive procedure with respect to pills, but later on, that comes back with some interest, basically. You put the money in the bank, and then the money gets a bit bigger, which is not what you see today. So I think it's a matter of 1 year versus 5 years follow-up and the primary endpoint. Rita 3 was death or MI. We hardly see any intervention today that is affecting death, even cardiovascular death. And in fact, that is only a confounder in the primary endpoint from a statistical standpoint, right? You have 2 components. One is significantly affected, the other one is not, and it's basically biasing the study towards the null. That is what it is. So the question is really how the study is designed, how the study is powered to also tease out the component of the composite endpoint and that follow-up, which drives a huge difference. Actually, I would reverse the reading of Rita. In elderly patient, there is no excess of acute kidney injury, of mortality, of adverse events, and perhaps a longer-term follow-up, you will have benefit.
Maybe just one additional comment to the guidelines. We just discussed it before. We have the new guidelines for the management of patients with chronic coronary syndromes. There we have novelties like the class 1 recommendation for intracoronary imaging, of course the shortening of the dual antiplatelet therapy, but we have also a third group of patients that is often neglected in the cath lab, are patients with ischemia and non-obstructive coronary artery disease, and this entity is further highlighted in the guidelines, also in terms of functional assessment in the cath lab. And I think this is important also to mention that we of course implant stents and take care of the medication afterwards, but we also doing very differentiated diagnostics for these patients. And not just do the coronary angiogram and say you have nothing, and because these are patients that are often very symptomatic and difficult to treat.
It's a great comment, Barbara. Thank you so much. In these guidelines, I think the focus is there on invasive, fully phenotype of the patient, not only looking at the epicardial vessel, but also microcirculation and spastic component of the epicardial vessel as well. Nothing really new, because in fact the ESC guidelines, I would say even 5 to 10 years ago, were already pointing there. But now the big difference is that the community is embracing this approach. And I think that gives a lot of validity back to patients, because I do see this patient keep coming for angiogram. You do the angio, you don't see anything. MRI is positive in this patient, or whatever. A non-invasive imaging is positive in this patient. They apparently have some proven ischemia, but you cannot document that in the lab, and these patients are completely confused. Now we have a message to tell them. The message is that we should try to identify the pharmacological cocktail which treats that ischemia. We don't have the right one. We need to try. It's a patient-by-patient exercise, but at least it's a beginning. Most likely in the future we'll have something dedicated, which will be great, actually.
Thank you so much, Marco. This was a fantastic overview of studies relevant to the field of coronary artery disease and antithrombotic therapy. And we transition now to the next session, and I would like to invite the co-moderators to join me. And it's my distinct pleasure to introduce our local host, Felix Mahfoud, who will give us an overview on the topic of heart failure and relevant studies presented at ESC.
Thank you very much, dear Stefan, dear colleagues. Talking about heart failure at the ESC, I think 2 topics have to be covered. One was already touched upon by Thomas Nestelberger, which is transcatheter edge-to-edge repair in heart failure with severe, moderate to severe mitral regurg. That is reshaped. It's a different population. You'll see it in a second as compared to Matterhorn. And I think the most dominating theme at ESC this year was really a mineralocorticoid receptor antagonist, finerenone as a new agent, but also a revised patient-level meta-analysis that has potentially the impact to change clinical practice. This is Reshape HF2, presented by Stefan Anker from Berlin in one of the hotline sessions. Again, different setting. Patients were randomized to a device group, and those patients received a MitraClip implant within 14 days after randomization, plus guideline recommended medical therapy, and the control group with medical therapy alone, unlike in Matterhorn where the patients underwent surgery. You can see that 505 patients were randomized in this study. It took a quite long time period, and that's also one of the limitations we have to keep into consideration. March 2015 to June 2024, almost 10 years to recruit these and follow these 500 patients. When speaking about these trials, I guess most importantly for external validity is to think and understand which patients were included in the study. Symptomatic heart failure patients in renal function class 2 to 4 with a left ventricular ejection fraction of 20 to 50%. They had significant functional mitral regurg. Everything was assessed by a core lab, which had to be 3 or 4. Patient had to have a hospitalization for heart failure within the last 12 months, or an NT-proBNP above 1,000 or a BNP above 300 picograms per milliliter. Again, external validity, which patients were then finally included in the study. You can see elderly individuals, 70 years of age. Most of the patients present with the typical comorbidities. 50% of the patients had atrial fibrillation. I guess one of the limitations that we have to talk through also during the discussion is the low usage of SGLT2 inhibitors in the study. Less than 10% of the trial's participants recently were treated with an SGLT2 inhibitor. Patients had functional impairment. The average, the median 6-minute walking distance was roughly 300 meters. You can see that the left ventricular ejection fraction was roughly 30%, so lower than what we have seen previously presented in Matterhorn. And importantly, left ventricular end diastolic diameter was round about 68 to 69 millimeters. So we're not talking about these mitral FR, very large ventricles. It's a little more like a co-opt patient population included in this study. Significant outcome in terms of the primary endpoint, that was recurrent heart failure hospitalization or cardiovascular death within 2 years of follow-up. You can see here a relative risk reduction of 36% for those patients who were treated with mitral clip. And when you look into the separate components of the primary endpoint, you can appreciate here that hospitalization for heart failure was also significantly reduced, almost halved, relative risk reduction, 41%. And I found it very interesting to see the curve separating very early, almost within the first 3 months. There was a separation of the curves indicating that TEER did better than control in those patients included in the trial. What about Kansas City questionnaire in terms of quality of life? Was there an improvement observed? Yes, 11 points, which is pretty high, but of course also related to the fact that this was an unblinded study, so the participant clearly knew whether they had been treated with the device. That's something we always have to keep into consideration when judging quality of life changes in an unblinded fashion. But we're looking into 6-minute walking distance, so symptoms and exercise capacity obviously also improved in these patients by 20 meters, which is considered to be clinically meaningful and relevant. I will not bore you with this slide here. You'll see a lot of these subgroup analysis. All of them were pre-specified in the statistical analysis plan, and none of those reached statistical significance. And of course, the more you test, the more the likelihood that one of these subgroup analysis becomes positive. But I think overall, there is no overarching subgroup that benefited more or less from MitraClip. Consistent outcome, the point estimate always favoring the device for almost all groups, including left ventricular ejection fraction, including the volume of the ventricle, and including mitral regurg severity. What was not observed, and I think that deserves also discussion, is the fact that death from any cause was not influenced. Neither was death from cardiovascular causes influenced by the device. So obviously we are more seeing an improvement in heart failure events here related to hospitalization, which was significantly improved, but no effect on mortality whatsoever, neither from any cause, total mortality or cardiovascular mortality. Interestingly enough, almost 10% of the patients in the control group were crossed over and received MitraClip implantation throughout follow-up, and that was, of course, highly statistically significant. So to summarize limitations and probably also conclusions of ReShape 2, I think a limitation is that this was an unblinded trial. The participants and the follow-up physicians were aware of group allocation. 38% of the patients in the control group received a MitraClip, which of course confounds or may confound the primary outcome. No effect on mortality observed. This appears to be a common theme for atrioventricular repair approaches. Long inclusion period, that's something we have discussed already, and low rates of guideline recommended therapy, in particular when it comes to SGLT2 inhibitor use, 10% of the population. Conclusions pretty strong, I guess. We've learned with this study and received another point of evidence indicating that mitral clip in patients with moderate to severe functional MR indeed led to lower rates of hospitalization for heart failure and cardiovascular death in combination. That was the primary endpoint. Lower rates of hospitalizations for heart failure, higher quality of life, and higher increased rate of capacity indicative by 6-minute walking distance. Let me continue by discussing some news about aldosterone and probably its inhibition, mitigation using new drugs and old drugs that are available as well. So we know that for sure the renin-angiotensin system plays an important role not only in heart failure but also in heart failure, and mitigating aldosterone through various pathways is possible and achievable now with drugs that are available. And finerenone was one of the agents that has been heavily discussed during ESC. It's a selective non-steroidal mineralocorticoid receptor antagonist, and very briefly, it's different from those that we are using, spironolactone and eplerenone, where you can see that the selectivity for the mineralocorticoid receptor is very high. We have no central nervous system penetration, almost no side effects, sexual side effects in particular, and very rare rates of hyperkalemia, at least in the previous studies that were published. Given the positive outcomes in patients with diabetic nephropathy, finerenone has been graded as a class 1 recommendation in the latest edition of the diabetes management guidelines by the ESC. Figaro, DKD, and Fidelio recommend the use of finerenone in patients with chronic kidney disease and diabetes with an impaired eGFR and proteinuria. Again, this is a class 1 recommendation. The question was open then on whether using this novel non-steroidal mineralocorticoid receptor antagonist in patients with preserved ejection fraction and mid-range ejection fraction would do good in terms of outcomes. It's a large randomized double-blind placebo-controlled trial, Fine Arts, presented by Scott Salmon. You can see that again, patients with symptomatic heart failure were included, left ventricular ejection fraction above 40%. They had elevated natriuretic peptides. They had to have structural heart disease, either left atrial enlargement or left ventricular hypertrophy. Some of the exclusion criteria are listed here. No severe impaired renal function, eGFR cutoff 25 mL per minute, potassium above 5 millimoles per liter was also an exclusion criteria, and certain cardiomyopathies, including peripartum and chemotherapy-induced cardiomyopathies, were also excluded. 6,000 patients, so a large study, were randomized to receive either finerenone that was uptitrated or placebo in a 1-to-1 fashion. Again, external validity, so which patients were included. I'll highlight few aspects that I think are important. Left ventricular ejection fraction on average, 53%. So this is more like the HFpEF population on average that was included. NT-proBNP, roughly 1,000. eGFR on average 62 mL per minute. 50% of the patients had chronic kidney disease defined by an eGFR below 60 mL per minute, but no proteinuria. Urinary albumin creatinine ratio was 18 milligrams per gram. Another side note, as you all know, SGLT2 inhibitors, a pillar of heart failure therapy across left ventricular ejection fraction. The use here again pretty low with 13 and 14% per group. Primary endpoint, cardiovascular death and total heart failure events. Nice outcome, significant reduction, 16% relative risk reduction in favor of finerenone. Here, an absolute rate reduction of 3.3% and a relative risk reduction of 16% through 3 years of follow-up. Looking into the components of the primary endpoint, you can see again that total heart failure events was also significantly reduced by 18%. But also in this patient population here, again, a HFpEF patient population that is dying mainly from other causes than cardiovascular death, where you can see here that through 3 years of follow-up, the cumulative incidence is less than 10%. And again, this did not translate, the use of finerenone did not translate in any reduction of cardiovascular death or all-cause death in this study. Another busy slide. I'll go with you through it very briefly. all point estimates on the right side indicating, I mean on the left side, so to speak, on the right side, indicating that finerenone was better than placebo, and no dedicated subgroup that appeared to benefit more or less from the drug as compared to placebo. So it reduces events. What's the price that we have to pay for it? Looking into safety, you can see here that when looking at any serious adverse event, there was no significant difference between the two groups. That's important, but a doubling of the incidence of serum potassium above 5.5 millimoles per liter was observed in the actively treated group, and the investigator-reported hyperkalemia was also doubled in the active treated group, and a slightly higher percentage of patients had a systolic blood pressure of below 100 millimeters of mercury. So to summarize limitations and then also to conclude, I guess we see here a pretty large trial, 6,000 patients in an HFpEF, HFmrEF patient population where the drug was tested against placebo. We do observe higher rates of hyperkalemia and hypotension. The drug was not tested against spironolactone or eplerenone. I guess that's a limitation, certainly. We need to monitor renal function because we see impairments in renal function in those patients as well. Low rates of SGLT2 inhibitor use. But to conclude, I guess finerenone is a novel agent, pretty potent agent in patients with HFpEF and HFmrEF that reduce cardiovascular events, including cardiovascular death and heart failure hospitalization, improved overall health status, and had no effect on mortality whatsoever. Neither all-cause mortality or cardiovascular mortality was consistent across pre-specified subgroups. Hyperkalemia was more common in the finerenone group, certainly something we have to watch out. And the question then comes, will that therapy be considered as a standard therapy for patients with HFmrEF and HFpEF? I guess more to come, more to be discussed, but certainly an attractive compound. And lastly, speaking about mineralocorticoid receptor antagonists, where do we stand currently? And you all know that one of the 5 pillars in patients with HFrEF is certainly the use of a mineraloreceptor antagonist. But you can also appreciate here that the use of MRAs in patients with HFmrEF and HFpEF has been graded with a class 2BB recommendation. So pretty weak recommendation as to use by current guidelines. And the question that was addressed by a recent independent patient meta-analysis, I think is worth discussing because this has truly impact on clinical practice. So patient level meta-analysis performed by John McMurray's group out of Glasgow, where they looked into 4 trials, including fine arts, so the one that I just presented. Now we're seeing a broad representation of heart failure from 30 left ventricular ejection fraction up to above 45, 13,000 patients included in that patient level meta-analysis. Left ventricular ejection fraction, broad range, 25 to 57. Anti-proBNP was not available in 2 studies, and the others was roughly about 1,000 picogram per milliliter. eGFR on average preserved. Again, a limitation of all these studies because they were conducted over a time span of 25 years, low rates of SGLT2 inhibitor use in the most recent studies. When you pool now the data and you get a lot of statistical power, you see significant impacts, not only for patients with HFrEF, as indicated here, with a 34% risk reduction for cardiovascular death and hospitalization for heart failure, but also in the HFmrEF and HFpEF population, there was a 13% risk reduction for cardiovascular death and hospitalization for heart failure, independent on which drug they have tested. So no, the P for interaction here was not statistically significant. Early separation, again, higher rates in those patients with HFrEF as compared to patients with HFmrEF and HFpEF. We're looking into hospitalization for heart failure, again, consistent outcome across a broad range of left ventricular ejection fraction from HFrEF to HFmrEF to HFpEF, significant reductions, 26% relative risk reduction. And also cardiovascular death was significantly reduced, mainly driven in this instance here by the HFrEF trials, not so much by the HFmrEF and HFpEF studies. Safety, and this is then my last slide referring to this meta-analysis, significantly higher risk of hypotension That's something we, of course, know. Higher risk of impaired renal function over time, higher risk of hyperkalemia observed in those patients treated with mineralocorticoid receptor antagonists. But the improvement on outcomes was independent of the drugs that were used. So to summarize limitations, I think it's important to note that not all variables were available across trials. There was heterogeneity, which was high, but not allowing for drug comparisons. Background treatment changed over time period, certainly of 25 years. Again, low rates of SGLT2 inhibitor use. But you know, you can look at this also from a different angle. With these 13,000 patients, we have much evidence indicating that mineral receptor antagonists reduce the risk of heart failure hospitalization and cardiovascular death in patients with reduced ejection fraction. That refers to abiraterone and spironolactone, HFmrEF and HFpEF for finerenone. Benefits were observed across subgroups. Risk of hyperkalemia was increased, but the rates of serious hyperkalemia were pretty low with 3%. So I think the conclusion from this meta-analysis should be that we should consider indeed mineral receptor antagonists in all patients with heart failure without contraindications for its use. Thank you very much for listening, and I look forward to your questions now.
Felix, thank you very much. I think we should start discussing the first topic. And with so many imaging specialists and heart failure specialists in the room, the discussion also in London was for the selection of patients sort of for mitral intervention. How much should be guided by the severity assessment of severe or perhaps slightly less than severe mitral regurgitation, of course, in patients with heart failure and reduced ejection fraction versus the clinical profile that at least there was some evidence with the interaction P of 0.03 that perhaps patients that had a hospitalization for heart failure in the previous year had the largest benefit. Could you give us your take on kind of the relative importance of these two variables in the selection of patients?
So certainly, you know, when you pick patients at a higher risk, you have a higher potential to do good to those patients with mitral clip or transcatheter edge-to-edge repair. Is there one single parameter that helps us to guide whether a patient is eligible or a good candidate or a bad candidate? That's something I doubt. So we have plenty of parameters that we assess. I think a general theme is that we should not intervene too late. Something that we have done probably in the past is, you know, treating those highly enlarged ventricles, left ventricular ejection fraction of 20%. I think, you know, those patients are not the ideal patients for any intervention, including mitral clip. Intervene a little earlier. Reshape, it's also important to note that there was an independent patient adjudication, so there was a committee who judged whether the patient was treated according to current guidelines. So a lot of, like in COAPT, a lot of efforts went into selecting really appropriate patients with almost perfect heart failure therapy, and on top then the mitral clip was performed and did quite well. So I guess it's more like discussion also with colleagues from cardiothoracic surgery to discuss whether, and heart failure, to discuss whether we all think and we believe that this is a potential candidate for mitral clip procedures.
Michel?
Yeah, my question is sort of along the same lines regarding the subgroup who had not been hospitalized during the 12 months before. And maybe it is a real difference because the primary endpoint is driven by heart failure hospitalization. So if you think about it, how likely is it that a patient who has not been hospitalized the year before will be hospitalized the year afterwards? So maybe maybe it is an indicator for a lower risk patient. Maybe you know how many patients are in our mitral clip population are hospitalized the year before. Probably most of them, I'd suppose. What do you think?
Most of them should be. Thomas, you know the numbers, I guess.
Yeah, it's definitely 70-80% of our patients have been hospitalized the year before, yeah.
I'm a little cautious with the subgroup analysis. I mean, that particular one makes sense, but they tested 30 subgroups, and this is the only one that was statistically significant. So just by chance, we should have one that is positive, right? In this circumstance, it makes sense for me too, that those at a higher risk for the event, did particularly benefit from the procedure. But is that, should we restrict ourselves to patients who were recently hospitalized? That's something I would doubt.
Felix, you also showed nicely in the ReShape trial, they did not only include patients with severe MR, also with moderate MR. So I think that's a big difference compared to COAPT and MITRA-FR. What do you think about that? So should we also now look for patients with moderate MR, with still symptoms despite optimal medical therapy, and probably offer them a treatment as well?
Yes, I think we should. And it's important that this was not investigator-reported MR severity, but core lab reported MR severity. So we look forward to seeing what the investigators thought this is. But it makes sense too, right? If there are clinical parameters that indicate that that patient may benefit from a TER, I think we should not restrict it to really those very severe ones. But here in the trial, 3 and 4 MR severity grades were included, and that makes sense.
Thank you very much, Felix. You mentioned decrease in hospitalizations that was around 40%. This is really striking, and we all know that heart failure hospitalizations are a real important signal for mortality later on, and you also showed that mortality was not decreased. How do you explain that fact? Is the follow-up too short, or do we know any results? Maybe the authors know the results from the very early patients that might have a follow-up of 5 years so far. Can you comment on this mortality thing?
So I asked exactly the same question to Stefan Anker, and he told me that this will be published very soon. So they are working on it. I guess they have some clues, and it may be the duration of follow-up as well. Yeah.
Felix, maybe to follow up on ReShape, I think what also needs to be said is in view of the high event rates in the population, both COAPT and ReShape, the number needed to treat is in the range of between 4 and 8, so a massive treatment effect. And I think, as already also mentioned by Ottmar, these were heart failure hospitalization at variance, for example, with what we may discuss in a moment, fine arts, where it is heart failure events. So the heart failure community moves more and more, also in view of the COVID pandemic, to that endpoint that embraces more. And therefore, what can we do to implement this on the same par as the 4 fantastic or magic heart failure medications, or what else is needed to bring these patients to a treatment that has this kind of impact?
Awareness, I guess, right? So it's talking about the outcomes, discussing it openly with colleagues, and particularly referring physicians. We are still intervening too late on these patients. I guess many of those patients are conservatively treated for years, and we, don't understand that this is a potential option for some of those patients who are conservatively treated. So feel free to send these patients to heart centers where there is a group that's taking care, and not all patients that you will refer will finally receive a mitral clip, right? There will be significant workup. We'll discuss the patients individually and then come to a final conclusion. But I agree with Stefan, overall awareness is definitely an issue. And when we look into prevalence of mitral regurg and significant mitral regurg, we should see thousands of these patients in heart centers, and we don't. So they have to be somewhere, and I guess they are, not referred because we are not aware that there is a minimally invasive and safe procedure available for these patients.
Besides awareness, there might be another target to impact outcomes. 50% in almost both groups had AFib. So what's your take on this? In surgical MR, you would do concomitant AF ablation. If a patient with severe MR and AFib gets referred to me, I'm very likely to perform an AFib ablation. If he gets referred to Thomas, he will do a mitral clip. So how should we tackle this?
Very good question. The answer is we don't know, I guess, for interventionally treated MR, but certainly something we should investigate in future clinical trials on whether the combination of two interventional procedures, in that case it would be pulmonary vein isolation and mitral clip, further improves outcome in those patients. Every second patient, as you correctly mentioned, had atrial fibrillation in Reshape.
Thank you, Felix. You're a master in clarity, so it's a privilege listening to you. I cannot resist the temptation to make a small comment and ask you a difficult question. A small comment is that it's important, that's been said already before, but I would like to reiterate it. Reshape has taken out the tension to judge whether that mitral regurgitation is truly severe, which is a discussion in the art team which is so annoying because, of course, it is time dependent, it's patient dependent, treatment
and volume dependent.
Yeah. So it's no sense to keep discussing the degree of severity. That is first comment. I'm sure that we go there also in the aortic stenosis space, but that will be later. I would like to pick up your brain because in studies I don't see reflected something which you do see in the clinical arena, which is once you do edge-to-edge repair, you can not only give the heart failure medication, but you can up-trade them much easy, which is something you cannot do before. Because if you increase the ARNI regimen, the patient has 55 of systolic pressure and cannot stand any longer. You do the same exercise after edge-to-edge repair, you can up-titrate the same class of drug, which is a tick box, yes, in the tables, but the dosing, the up-titration is never reported. Do you have that perception in your practice as well?
Yeah, and there's data published in JACC Heart Failure where they looked into the Permanente healthcare database and they found that post-TER, the usage of guideline-recommended heart failure therapy was significantly higher as prior to TER. Whether that's related to the physicians that are taking care post-TER on the patients, we don't know, but certainly there's at least some evidence indicating that up-titration and escalation of guideline-directed medical therapy is possible and probably enabled also by TER.
Felix, thank you very much for your great presentation. So there was no difference in mortality. Do you think this is also a reason by that we intervened too late? And do you know, were there some data for the patients with moderate MR? Was there a sign to a difference in mortality maybe?
So 500 patients have had severe and half had moderate to severe MR. So we're speaking about 250 patients, and there was no statistically significant difference in either of these groups, right? Severe or moderate to severe MR. Am I surprised to see that? Honestly, no, because I think, unlike with TAVI, where we know that we are improving mortality post-procedure, I think this is more related to reduction of heart failure events long-term. You need more patients to see an effect on outcomes when you reduce heart failure hospitalization. So I see this whole AV space more as a space where we reduce heart failure events, improve quality of life, exercise capacity, and not so much focus, and should probably also not focus so much on mortality and cardiovascular death.
So Felix, thank you very much also for the second part of your presentation, the MRA and Finerenon. Just perhaps a quick question to finalize this part of the session. So you showed us the data, and in your personal opinion, who would be the ideal candidate now to start with Finerenon? Would it be the patient with a HFmrEF, HFpEF, or first focus on the diabetics? Or do you think it's already the time to say, okay, this will be the new standard of MRA in the heart failure patients?
So first, this study enabled a meta-analysis that provided a pretty strong recommendation and evidence that we should use MRA across the spectrum of left ventricular ejection fraction, And I would go so far in saying probably independent of the drug that we use, right? That's a very strong message. Class 2, I think it will receive a Class 2AA recommendation in a previous edition, probably MRA use across the spectrum, have MREF and HFpEF. And who's the ideal patient? I would personally stick to those patients with chronic kidney disease and proteinuria as recommended by current guidelines, because there we have very strong evidence that Finerenon really not only reduces cardiovascular events, but also renal events, prolongs the time without end-stage renal disease, and improves overall quality of life of those patients. So I would restrict it currently a little more to those who have comorbidities, heart failure, probably in combination with diabetes, or diabetes in combination with chronic kidney disease and proteinuria. And once available, I guess, in the HFMREF population, that's certainly a drug of interest.
Thank you very much, Felix.
Thank you.
We would now like to go on. So the next session is about electrophysiology and the highlight sessions and the highlight studies that have been presented at ESC. And Christian Sticherling, Head of Electrophysiology Department of University Basel, will now present us very interesting data.
Yeah, thank you, Christine. Ladies and gentlemen, it's my privilege to present the most important data from this year's electrophysiology sessions at the ESC. And I promise you, I really try to look hard for trials that are not dealing with AF, but right now I didn't find them. Particularly, the prime stage seems not to be open yet for the very exciting field of conduction system pacing. The trials that have been presented there were of a relatively low quality, and I'm thinking we can look forward to interesting trials in the near future. But for the time being, there were a lot of trials that are also very relevant for the practicing cardiologists, and they all deal around the topic of atrial fibrillation. So the first trial is the Oceanic AF. And this trial will show us whether we have better anticoagulants that help us to treat our patients. Are there maybe even drugs that avoid bleeding? Because that's what you are discussing back and forth with your patient in practice. The second trial is that with the new goods you're all confronted with, the new products like wearables, like patches, like devices, device-detected AF, do we do any good to the patient if we screen them and in turn then, when we find atrial fibrillation, start oral anticoagulation early? So can we prevent strokes, these devastating appearances or things that can happen to patients? And last but not least, maybe more for the interventionally working community, the pulmonary vein isolation. We have never shown in a trial that we prolong mortality. The Cabana trial in 2019 had a lot of crossovers, a lot of problems, but it failed to show mortality benefit. But do we do any good to our patient, or is it just placebo effect? My boss, Felix, he knows a lot about placebo effects. He has been involved in the Simplicity trials, and this almost a decade ago really led to a return in thinking about renal denervation. So let's kick off with the Oceanic AF trial. As you know, we nowadays treat most of our patients with direct thrombin inhibitors like dabigatran or factor Xa inhibitors, like all the other NOACs. And it is appealing that people found out that persons with hereditary factor 11 deficiency had lower incidences of stroke, but they did not tend to bleed more than other patients. And that highlights the fact that factor 11A is not so important in hemostasis, but it is very important in the generation of pathological thrombi. And therefore, these may be a molecule which could be a perfect target, because we hope that the bleeding rate will go down and that the stroke prevention will be the same. Just as a background, 2 years ago, Pacific AF, a phase 2 trial has been published, and they used the asundexian, which is a direct factor 11A inhibitor, a very attractive drug because it's orally available, it's given only once daily, only 15% renally excreted and long half-life. And the first trial they did is they randomized in the phase 2, and so that is the safety trial, 755 patients 1:1:1 to two dosages of asundexian or apixaban, and they were then looking at bleeding. And the first thing that you can see here is this is the ratio of the baseline factor 11A activity at dosages of 20 and 50 milligrams. It highly effectively suppressed the activity. And that was a very nice finding. If you look at the bleeding rate, and this is the overall bleeding here in the dark green color, you can see that with asundexian 20 and 50, there was a significant reduction in bleeding. So there's a drug that is easy to take, not too much renal excretion, also potentially feasible for our patients with end-stage renal disease, and it doesn't bleed. So now the question of oceanic AF was, does it also prevent strokes? And therefore, they executed this trial in a non-inferiority design. And the question was whether the high dosage of 50 milligrams of asundexian is at least non-inferior to apixaban for the prevention of stroke and systemic emboli. And it was also powered to determine whether asundexian is superior to apixaban in the reduction of major bleeding and in a net clinical benefit endpoint combining stroke, embolism, and bleeding. So for that purpose, people with atrial fibrillation were enrolled. They had to fulfill certain risk criteria. They needed to have either rather high CHEST-VEST scores or lower CHEST-VEST scores, and at least one additional risk factor like age, previous stroke, renal dysfunction, stuff like that. Just as a side note, as of today, we will not talk about CHEST-VEST score, but CHEST-VE score, because in the new guidelines that will be presented tomorrow, the sex category was omitted. So get used to CHEST-VE. But all the trials are done with CHEST-VEST. And as you know, and you probably heard it in the lay press, it has been terminated prematurely on November 19th, 2023. And the reason was that they could not find, no superiority, but there was actually a sign for harm. Okay, so this is the first time, though, that the population has been clearly identified and has been published concurrently in the New England Journal. And I just want to point out a couple of things. It's an elderly population, 75 years old. The CHEST-VEST score was really high. So CHEST-VEST score of 4 is high, like in the early NOAC trials, like in ROCKET, for instance. And the type of atrial fibrillation, and I think that's worth mentioning, is different from the old NOAC trials, because there we had more long-standing persistent or permanent atrial fibrillation participants. Here, almost 40% were first detected or paroxysmal. And as an electrophysiologist, that means that these are patients who are not so far down their journey with atrial fibrillation, and maybe the atria are not as diseased as with long-standing persistent. And this was the outcome, and that was very sobering, really. You can see here that on the apixaban arm, over close to 1 year, the stroke or the primary endpoint was reached at 0.4%, but with a high dose of the factor XIa inhibitor, 1.3%. So the hazard ratio for risk was 3.8, and that was a reason why the trial was terminated. So maybe just try to digest these numbers, 1.3 and 0.4%, and reflect on whether that's a lot or not so much for you. But at any rate, there is a difference, and that justified to terminate this trial. It was doing what it was supposed to do. It didn't bleed. So the bleeding rate was reduced by 68%. So the conclusion on oceanic AF is that treatment of patients with risk factors with asundexian 50 milligrams once daily is associated with a higher risk for stroke or systemic embolism when compared to treatment with apixaban. And I think we will discuss later whether the chapter is closed on that, but I already highlighted that this population is a little different from the ones that we studied before, and I think it's also important that we bear in mind how high the event rate for stroke and embolism actually was. So there are more trials ongoing. The Librexia trial is dealing with another orally anti-factor 11 molecule, and there is the Azalia TIMI-71 out of Boston with a monoclonal antibody abelacimab versus rivaroxaban, and we'll see what these trials will bring because their inclusion criteria are also a little different. Okay, so the second important study, GUARD-AF, and there was actually At the same hotline session, another trial from Sweden, the Stop AF2 trial. And here the question is, does it make sense that we screen patients? So screening becomes pretty easy nowadays. You can see here one of these 14-day patches that we also use a lot here in Basel. If we apply that to the correct patient population and we detect atrial fibrillation, and then we start to anticoagulate these patients, will we succeed in decreasing this most horrible outcome, stroke in patients with formerly unknown atrial fibrillation? So this is a very high goal to reach, but it's worth it because it has a lot of implications. So that was the design of the GUARD-IF trial. It was conducted mainly in the western part of the United States. And here, people who were insured with the Kaiser Permanente group in California or with Medicare and Medicaid in the western states of the United States were offered to receive a 14-day continuous single-lead monitoring patch or being randomized to receive one of these patches. And the investigators tried to enroll 52,000 patients. And you can see here after randomization, they either had for 14 days this Zio patch or just usual care. The median follow-up of the patients who were enrolled was 15 months, but the trial had to be terminated early after only 1/5 of the patient, namely approximately 12,000, had been enrolled. And that was due to the COVID-19 restrictions in place at the time in the respective states of the United States. So these are the baseline characteristics. You can see it is an elderly population, so that's really a population we are dealing with in everyday life. Noteworthy, one of the very few cardiovascular trials where the female sex had been appropriately represented, even a little bit overrepresented. 55 or 56% of the participants were female, maybe also reflecting a greater willingness of participating in clinical trials. The follow-up was 15 months, and as I said, the CHEST-VAS score was around 3, so lower than in the Oceanic AF trial. And that is the result as to detection of atrial fibrillation. And you can see that when you screen, you had a 4% detection per 100 patient years, as opposed to 2.6 in the usual care group. That translates into a 52% increase in detection in the screening arm. If you look at the curves, it's interesting that the participants were only carrying the device for 2 weeks, but you can see that the curves are separating afterwards. So I don't know what this is due to. Maybe it's a Hawthorne effect or something like this, but it's interesting to observe. And what is also interesting for us as the EP community, at least, if we look on the device in the 250 patients who had detected atrial fibrillation, how long that actually lasted. And for us, probably more upcoming and more important measure is the AF burden. That is the time in atrial fibrillation of the respective patient. And you can see here on this bar graph on the left, this is percent time in AF 1% or less, and this were more than 50% of the patients. And the vast majority of the patients, the vast majority were not in permanent atrial fibrillation, and only a very few here were virtually all the time 100% in atrial fibrillation. So the vast majority was in AF for less than 10% or even less than 1%. And this may become important in the interpretation of the data. And that is a primary efficacy endpoint. So the patient who were identified as having atrial fibrillation were started on NOACs, and regardless of whether you started them or the ones in the screening group and then the usual care group, did not have a difference in the primary efficacy endpoint of stroke. So this is just another sobering result after the loop trial with more than 6,000 patients where an implantable loop recorder was used to identify the patient, and the Swedish stroke stop trial with 120,000 patients where we could also not find a decrease in stroke rates with AF screening. There was no concern in terms of the safety endpoint. And the conclusion of the paper is that screening for AF using a 14-day continuous ECG monitoring in people greater or equal than 70 years did not reduce the hospitalization for stroke, so it's 0.7 versus 0.6%, but increased the detection rate of atrial fibrillation by 52%. And in the EP community now, for us, it's really important to know whether it's worth to looking for the needle in the haystack, or whether we should first try to identify the right population at risk who will benefit from this screening. So that's the old question about which screening measures make sense and which don't. Okay, and that brings me to the last trial, the sham PVI trial, a trial that can, of course, only be performed in the United Kingdom, in the NHS. It's a sham-controlled trial. The community has been talking about it for ages. Nobody dared to do it. But two NHS trusts, one in Essex and another one east of London, actually undertook this endeavor, and they enrolled 126 patients who were scheduled for pulmonary vein isolation. 2 weeks prior to the procedure, they received an implantable loop recorder, as you can see here. So at the time of the procedure, we already knew which percentage of the time they were in atrial fibrillation. They then underwent cryoablation, which is a relatively easy form, well-established form for pulmonary vein isolation. And 64 really underwent the isolation, and the other 62 received a sham procedure. And the sham procedure included puncture of the groin, and they were also advancing catheters into the heart, and they were pacing the phrenic nerve, because when we ablate the right-sided veins, we try to avoid damage to the phrenic nerve. In order to monitor that, we have to stimulate the phrenic nerve, and that results in a twitching, a very uncomfortable feeling like a hiccup of the right diaphragm. So the patients had all this feeling, so they got the same as the ones who underwent the real procedure. The primary endpoint then was the AF burden measured in these devices at 6 months after a 3-month blanking period, and then as secondary endpoints, Nurmo's quality of life measures. And importantly, and that's also different from other trials, there were absolutely no crossovers. So this is the patient population. You can see here, and I need to point that out because this is something that is so different from our population. In the NHS right now, I just talked to a colleague from Coventry in London. In their NHS trust, the waiting time is 9 to 12 months right now to receive an AF ablation. And so it's not surprising that almost 80% of these patients came in persistent atrial fibrillation. Here in Basel, I'd say we have approximately 40% in persistent atrial fibrillation, and the rest is still paroxysmal, again reflecting probably an earlier stage of the disease. From the procedural characteristics, you can see here that the procedure time was very comparable, but what's also important is that 80% of the patients, namely all with persistent atrial fibrillation, got cardioverted before then the actual procedure was conducted. And that's the primary outcome, AF burden. You can see at baseline the AF burden was really high. You now learned already from GUARD-AF that in another population it is as low as 1% in the majority. Here we have 80% in both groups. And then after 6 months, there was a 75% relative reduction in AF burden, 43 in the sham group and 18 in the intervention group. All quality of life measures, the AFQ-QT, the Mayo Clinic AF score severity index, and the SF36 scores, they were all favoring the procedure in all different dimensions. There was really not a single sign where the sham procedure was any better. So in conclusion, the sham PVI resulted in a significant decrease in AF burden at 6 months. It also resulted in substantial improvements in symptoms and quality of life for patients, and at least until now, there was really no sign of placebo effect with PVI. And I think there's a lot to discuss, and I'm really looking forward to an eager discussion with you. Thank you.
Thank you, Christian, for this very clear and well-balanced presentation. I will start a discussion with Oceanic AF. So you showed us the safety data from Pacific AF with dramatically low bleeding rates. So there was a huge promise regarding safety. Now, asundexian failed its primary efficacy endpoint. My first question would be, why didn't it work?
Well, that's difficult to say. So there was a very, very lively discussion around this trial. And one discussant said, you know, it took us 50 years to show an advantage of NOAC over warfarin. So why do we expect now 1 or 2 years to show an advantage of factor 11 over the other NOACs? I think we are really at the early days, and it may be that it was underdosed. Maybe there's not enough knowledge of pharmacokinetics or dynamics in these patients. And there are 2 more trials with different designs and also different study populations, which may shed a different light on it. For now, we don't see anything, but for me, that does not mean that the chapter is closed. And another thing that is really important, and I can't overstress that in all AF trials. When we look at Averroes, for instance, an old AF trial that was conducted 15 years ago. In the apixaban group, the stroke rate with a CHEST-VASc of 4 in patients older than 75 was 2.6%. And now here we had 0.4% with apixaban and 1.4% on asundexian. So the background risk is going down, and that also, of course, means that we need larger trials.
Perfect. Any other questions from the audience?
To your left.
You know, just to follow up on the asundexian, I'm asking myself, first of all, regarding the endpoints. I know it is customary in the AFib trials to use efficacy for stroke and systemic embolism. Let's say in the interventional field or other antithrombotic fields, you would look for net clinical outcome, that is for death, stroke, and life-threatening bleeding. And there the story certainly wouldn't look so negative for the factor 11. And therefore, to be honest, I'm a little bit surprised that they abandoned the drug, at least on part of Bayer, whereas it will be continued with the milvexian, because even if, let's say, it is inferior in a certain risk population, you still have those patients with bleeding. You have those patients with intracranial hemorrhage. And just if you project yourself in the future when Champion and Catalyst will be positive and everybody has LAA closure, maybe it is an appealing agent on top of LAA closure.
Yes. Yeah, well, thanks for that comment. Yes. Actually, it was a pre-specified superiority endpoint, the net clinical benefit. But it was not the primary non-inferiority endpoint.
If there are no other questions for Oceanic AFib, I suggest we continue with GUARD-AF. GUARD-AF was another large-scale screening trial, another one that showed us the more you look for AFib, the more you're going to find. Now we have Loop using implantable loop recorders. We have Stroke Stop, as you mentioned, using a handheld single-lead ECG device. GUARD-AF used a wearable ECG patch. What did we learn from this trial regarding future large-scale screening trials? Which device should we use and which population should we screen?
Yeah, I think the more important question really is which population should we screen? There was also STOP-AF2 presented at the same sessions, and they added as a risk stratifier or modifier anti-BNP, pro-BNP levels of more than 125 picograms per liter, I think. And they thought that the patients with signs of heart failure or increased pro-BNP levels would fare better, but there was also really no sign. I think we need to think differently about atrial fibrillation these days. I like to compare that to the chronic coronary disease. You know, if we have somebody with angina and we place a stent, then we are never happy with the stent alone, but we start to treat risk factors. And with pulmonary vein isolation and with atrial fibrillation, we tend to see the arrhythmia completely isolated. And then we say, okay, we ablate it. if it's recurring, it's a failure. And I don't think that's the case, because I think in the patients with a very early onset of atrial fibrillation, we can still impact a lot by a combination of ablation and treating the risk factors. Because who knows, it may be that we need to have enough atrial cardiomyopathy caused by hypertension, other risk factors, diabetes, in order to actually enable the atrium to form a clot. Otherwise, we could not explain why so many people with atrial fibrillation and no risk factors never experience a stroke. And when it comes to the device, loop recorder is too expensive, patch is too short, and they had this handheld devices, the Omron device in the Swedish trials, where they transmitted ECGs twice a day, and I think that will probably be the way to go, or even wearables in patients who are capable of using them.
And as an Artesia investigator, you have many, many insights regarding device-detected AFib.
Yes.
Can you comment on any AF burden for screen-detected atrial fibrillation that would merit any kind of measures, such as anticoagulation?
Yeah, that is another very difficult question. AF burden was not really directly related to anything. What was related to outcome is a high CHEST-VEST score in Artesia only, not in NOAA AF. So that we put forward in this JACC publication that if your CHEST-VEST score is more than 4, so 5 or higher, in a patient who only has device-detected atrial fibrillation, then there may be, or then the benefit outweighs the complications and the risks of oral anticoagulation. So really toning down a lot, at least in Switzerland. We put a lot of these patients on NOACs with device-detected AF, and I think for the vast majority right now, there's no data to support that anymore. I did not present the data here, of course.
Thank you. Misha?
So back to screening, I have one of the problems I have with the screening trials is that I think the flaw they have is they usually look for atrial fibrillation, but we don't know whether all atrial fibrillation is the same and merits anticoagulation. So we would actually need, what's the number needed to screen to prevent one stroke?
Yes.
And whether you cause harm by looking for atrial fibrillation because you find other things, and that causes medical attention. And I think the numbers that are needed to screen to prevent one stroke are calculated probably around 20,000 to 30,000 subjects to prevent one stroke.
Yes.
So that's never cost effective, but maybe that will change in the future with wearables. If the patient buys it himself, it's on him. What do you think about that?
Well, I mean, you said it already. Maybe we don't even need to look for atrial fibrillation. Because, if the incidence of stroke is so low, and really, I mean, it is really low. Also in oceanic AF, it's very low. Even in the asundexian group, only 1.4%. I think we need to look for risk factors, or we need to look for better markers that tell us that the atrium is already diseased. And there was a very interesting, in one of the late-breaking trials, very interesting trial by Larissa Fabritz from Hamburg, and they were looking at, I think, 15 different biomarkers from East AFNet, and they saw that they could predict with 4 of them, with a very, very good prospective value, the occurrence of atrial fibrillation. They did not show, of course, that this translated into stroke, but that at least would lower the number of patients to screen. And since the biomarkers already changed, we not only have an electrical equivalent of disease, but also something more physiological, pathological in the biomarker expression and composition.
Then let's move to the third trial, very exciting, sham PVI. For decades, especially the non-EP community demanded the sham control trial for pulmonary vein isolation. Are now all questions answered?
Well, I mean, there was certainly a big, big sigh of relief amongst all electrophysiologists when we were there, because, of course, we believe in the concept. Well, I think there's no reason to doubt that pulmonary vein isolation works symptoms-wise in reducing burden. But I pointed out that the population that was studied here is a different population than the one that we are treating here in Switzerland. 80% persistent atrial fibrillation, that's a lot. We don't have that. I don't know that this would really require a new trial to show an advantage there.
You know, just to follow up on this, I found the results remarkable. That is the differential. So not just a positive result, but the extent of the differential is clearly positive. My question would be with contemporary techniques, that is in Basel, are you even better than their active arm?
No, I don't think so. Because I think the technologies are so good that we are probably already treating the patients where the atrial fibrillation is really derived from the pulmonary veins. We need to find out more on the pathophysiology and other targets.
Misha?
What I find interesting with the trial is that it's not actually a sham trial. It's actually ablation versus cardioversion.
Yes.
So in your opinion, does that make the trial more valid with regards to, or less valid with regards to the findings?
Well, I think you're absolutely right. So there were 80% were cardioverted at the procedure, and then there were another 40%, roughly more or less in both arms during the first 3-month blanking period. Well, I think the key is that there was a big difference after 6 months, and this was really a massive reduction of 75%. So for me, it does not really change the value of the trial.
And sham PVI gives us some insight regarding endpoints after catheter ablation for AFib. We always used to have this endpoint of any recurrence of any atrial arrhythmia. And then if a patient has long-standing persistent AFib, he gets an AFib ablation, and then he has paroxysmal AFib with a short duration, it's still a failure. Now we moved on to AF burden. The primary endpoint in sham PVI was AF burden, and the other endpoint was quality of life. So in future catheter ablation trials, which endpoint should we take?
Well, I was surprised at the first place that they did not choose quality of life, because that's what really matters here. And we will, of course, never be able to replicate AF burden trials because we don't have enough long-term monitoring capabilities. I think quality of life is what matters for the patient, but separately from that, it is our task to continue to evaluate whether they need to be on oral anticoagulation or oral anticoagulants or not. This has not been answered by this trial. It's just about patient symptoms.
Any other questions from the audience?
Good, so time for coffee, I suppose.
Then thank you so much, Christian.
Yes, okay.
Then it's time for a 15-minute coffee break.
Ladies and gentlemen, the microphone is, now it's working. Thank you. Ladies and gentlemen, it is my pleasure to announce or start the second half of the afternoon and announce Dr. Lukas Lauder, Oberarzt here at the University Hospital in Basel and a specialist in hypertension. He's also part of the new guidelines writing committee. And please, Lukas, enlighten us what's new in the 2024 hypertension guidelines.
Yes. So thank you very much for inviting me to give a short overview over the new guidelines for hypertension and elevated blood pressure. These are my potential conflicts of interest. First of all, the most obvious change in the guidelines is that we now have a guideline for the ESC only. In the previous guidelines, we had the ESC-ESH combination. The ESH has published their own guidelines last year, and as you know, the American societies will publish their guideline next year. So there's quite a transition, and we have a variety of guidelines on the market. And another significant change in this version of the guidelines is the name. So now it's not only the guideline for hypertension, now it's the guideline for the management of elevated blood pressure and hypertension. First of all, I would like to comment on the classification and how to measure blood pressure. The definition and classification of hypertension has changed. It was simplified. Previously, we had 7 different stages or classes of hypertension. Now it's only 3 to remember. Hypertension, that's the good news, is hypertension, has not changed. So in contrast to the American guidelines, hypertension is still defined as an office blood pressure of more than 140 or more than 90 millimeters for diastolic blood pressure. Then the new guidelines define non-elevated blood pressure as a blood pressure below 120 and below 70 millimeters of mercury for diastolic blood pressure. And in between, we have patients with elevated blood pressure. So now you might think that's completely nonsense, and you might be right in some aspects, but there's a good reason behind changing classification. Because we want to raise awareness and prevent patients from becoming hypertensive. So it's an approach to treat patients, or not treat, but manage patients before they even have hypertension. So it's really primary prevention and not only secondary prevention. The guidelines always use standardized blood pressure measurements as a reference. So if you don't have the time or or you're not feasible to measure office blood pressure as recommended by guidelines in your practice, routine office blood pressure values are usually 5 to 10 millimeters mercury higher than standardized office blood pressure measurements. But obviously the guideline recommends using standardized blood pressure measurements. First of all, we have to acknowledge that blood pressure is different in every individual patient, and every individual patient, or most patients, have different optimal blood pressure values. That's why the guidelines do not define a single value as optimal. For example, women usually at a younger age have way lower blood pressures than men, so the optimal blood pressure for a female is different than for a male patient. And if you look at the left graph showing the lifetime trajectories for systolic blood pressure, you can see that there's a larger gap or delta between the ideal blood pressure or normal blood pressure in a woman and the definition of hypertension. And we know that women have a higher central blood pressure than upper arm blood pressure, so there's even more risk to experience cardiovascular disease at lower levels of blood pressure. And the second reason why the guideline has introduced elevated blood pressure as a new concept or as a concept is that we have to acknowledge that a large burden of cardiovascular events occur at elevated blood pressure levels. In this meta-analysis, cardiovascular event, 30% of the disability-adjusted life years lost related to cardiovascular disease occurred in individuals with blood pressure between 115 and 140 millimeters of mercury. Now, don't get me wrong, it's not about treating every patient with elevated blood pressure, but it's about identifying patients at a very high cardiovascular risk and treating those patients to prevent cardiovascular events. We have to acknowledge that contemporary blood pressure-lowering trials incorporate cardiovascular risk for different reasons, but mainly to enhance outcomes and to treat those patients who really need treatment, those with a low number needed to treat. For example, SPRINT included patients with increased cardiovascular risk, and ESPRIT and CR, HCP did so as well. And all of these trials did not only reduce symptoms, but they reduced hard cardiovascular outcomes. So, What are we going to do with the new definition and classification of hypertension? First of all, lifestyle interventions are good for every patient. That's not a reason why elevated blood pressure was introduced. It's about treating those patients with lifestyle interventions to avoid the need of pharmacotherapy. All patients with hypertension have a high cardiovascular risk, and it's sufficiently high to allow blood pressure lowering pharmacotherapy. In patients with elevated blood pressure, if they are at a very high or high cardiovascular risk and they have a blood pressure above 130 or 80 millimeters of mercury, you should use blood pressure lowering therapy after 3 months of lifestyle intervention if blood pressure remains higher than 130 to 80 millimeters of mercury. The risk-based approach is not completely new. It's a concept that was already introduced in the 2018 guidelines for hypertension, where patients with cardiovascular disease, especially those with coronary artery disease, should already have been treated at levels of above 130 and 85 millimeters of mercury. And the 2023 ESH guidelines also introduced treatment for patients with a history of cardiovascular disease if their blood pressure was above 130 or 80 millimeters of mercury. So how do we manage patients with elevated blood pressure? The first step is to think about cardiovascular disease. Do the patients already have an established cardiovascular disease? Do they have moderate to severe chronic kidney disease, hypertension-mediated organ damage, diabetes, or familial hypercholesterolemia? Because we know that these patients have a high cardiovascular risk, and it probably is beneficial to treat them with pharmacological therapy. If none of these situations is present or none of these diseases is present in our patient, the guidelines ask us to calculate cardiovascular risk using SCORE2 or SCORE2-OP. So basically the same tool that was already introduced by lipid guidelines and is pretty much recommended in almost every of these patients already for lowering lipids, not only because of blood pressure. So if the cardiovascular risk is low, below 5%, then there's nothing to do other than lifestyle measures. If cardiovascular risk is high, more than 10%, then the guidelines recommend lifestyle measures. And if blood pressure is still above 130 to 80 after 3 months of lifestyle measures, then we should introduce pharmacological therapy. For patients in between, the guidelines now allow looking for shared risk modifiers and looking for sex-specific risk modifiers. Sex-specific risk modifiers are, for example, diabetes or pregnancy diabetes or hypertension during pregnancy, because we know that these patients, although their blood pressure might not be 140 over 90, they are still at a 2-fold or even 4-fold cardiovascular risk following pregnancy. Or preeclampsia, we know that 1 out of 7 patients has proteinuria after pregnancy, which doesn't go away. Or we look at shared risk modifiers. These are the classical cardiovascular risk modifiers, such as family history of premature onset of atherosclerotic cardiovascular disease, autoimmune disease, HIV, or severe mental illness. If one of these risk modifiers is present, we should consider upclassifying the patient to a high-risk category. And if none of these risk modifiers is present, and you have the ability to do these investigations, and if the patient wants these investigations, you can consider, but that's only a weak recommendation, to look for cardio or for end organ damage, for example, using coronary calcium score, or looking for plaques in the carotid or femoral artery. But that's only a 2B classification. So how do we confirm hypertension diagnosis? And the guidelines are now very clear about that we need out-of-office blood pressure measurements in pretty much every patient. It doesn't have to be 24-hour ambulatory blood pressure, but the guidelines recommend using home blood pressure monitoring if it's standardized, because we know that patients who use home blood pressure monitoring, they're more adherent. It's more likely that they're going to have blood pressure control than patients who do not care about their blood pressure, and than patients who are not involved in their blood pressure management. The tests recommended in the initial workup, they're pretty much unchanged, even slimmed down a little, but the guidelines emphasize the need to measure urinary albumin to creatinine ratio in every patient with hypertension to look for cardiovascular organ damage. How do we treat patients with elevated blood pressure at a high or very high risk, or patients with hypertension? First of all, we have to define a treatment target. The optimal treatment target stays the same. It's 120 to 129 for systolic blood pressure and 70 to 79 for diastolic blood pressure. But the guidelines always emphasize two key concepts. First, we should always consider frailty instead of age, because we know that a very old patient might be fit, but a younger patient might be very frail. So we can use different measures. Usually common sense is good enough, but if you need some help, the guidelines recommend using the clinical frailty score. It's a fairly simple score from 1 to 9 just to assess frailty. And the second concept is ALARA, which means as low as reasonably achievable. And most important, the patient has to tolerate the treatment. The guidelines also underline the importance of lifestyle interventions. First of all, they recommend increasing potassium intake if potassium intake is rather low and sodium intake is high. They recommend optimizing weight. They recommend physical activity and obviously restricting alcohol intake. Regarding physical activity, we've known for a long time that aerobic exercise is very beneficial, but recent analysis, studies, and meta-analysis have shown that dynamic exercise training and isometric resistance training is even more sufficient in lowering blood pressure in long term, so the guidelines recommend using a combination of aerobic exercise and isometric resistance exercise. The algorithm for pharmacological therapy is quite similar to the previous guidelines. The guidelines recommend a low-dose double combination therapy of a RAS blocker, calcium channel blocker, or a diuretic. Initial monotherapy should be preferred in patients with elevated blood pressure, so there's no sense of introducing a combination therapy in these patients with only slightly elevated blood pressure. Monotherapy is also recommended in patients with moderate to severe frailty and patients who already have orthostatic hypotension or are very old, aged more than 85 years. Beta blockers are always allowed if compelling indications are present. If blood pressure remains uncontrolled after 1 to 3 months, then the guidelines recommend adding a third drug at low doses, and that's probably a small novelty, or at least it's clarified. Always prefer adding a drug before increasing the dose. So we have a low-dose triple combination therapy of a RAS blocker, calcium channel blocker, and a diuretic. And then the next step would be to increase the doses of those first 3 drugs, the first-line therapies, before adding a 4th drug. If blood pressure is controlled, then the guidelines recommend following up the patient at least every year using normal office blood pressure values, or even better, out-of-blood pressure measurements. How do we manage patients with resistant hypertension? And that's a complicated figure, because I'm not really a fan of the figure, and the figure does not really represent what the guideline task force voted on. First of all, we have to clarify that in patients with resistant hypertension, which is defined as an office blood pressure above 140 to 90, that hypertension is really resistant. So we have to confirm resistant hypertension using out-of-office blood measurements and make sure that the patient does not have a cause of pseudo-resistant hypertension or secondary hypertension. So if a patient has resistant hypertension, the guidelines recommend spironolactone as a 4th drug and a beta blocker if not already initiated as a 5th drug. And then we have all these second-line antihypertensive drugs without every evidence having a class 2A recommendation and a shared decision-making process where we can ask the patient whether or not he prefers an intervention such as renal denervation or a drug. And we have to be quite clear that the evidence is actually the same for spironolactone and renal denervation. We have very good data from good studies that it lowers blood pressure. Both is fairly safe, or spironolactone is fairly safe, renal denervation is safe. And the guideline actually, in the text and the recommendations which I voted on, argue that in every patient with treatment-resistant hypertension with more than 3 drugs, you have the choice to discuss with the patient whether or not he wants a 4th drug or if he wants a procedure. So if we look into the text regarding renal denervation, the guideline says to reduce blood pressure and if performed at a medium to high volume center, different national societies have thresholds. For example, the German society recommends 30 interventions during a per center. Renal denervation may be considered for resistant hypertension in patients who have resistant hypertension and who express a preference to undergo RDN after shared benefit discussion and multidisciplinary assessment. The guidelines also recommend that renal denervation may be considered for patients with increased cardiovascular risk and uncontrolled hypertension on less than 3 drugs if they express a preference to undergo RDN after a shared risk-benefit discussion and multidisciplinary assessment. So what's the background? We know that renal denervation lowers blood pressure and it does not require adherence. We do not have direct evidence for lowering cardiovascular outcomes. That's why it's not a class 1 indication, and that's why it's only a class 2 indication, but it lowers blood pressure. And the 2 class 3 recommendations, due to lack of outcome trials, RDN is not recommended as a first-line therapy, and renal denervation is not recommended for treating hypertension in patients with moderate to severely impaired kidney function. That means an eGFR below 40 milliliters per minute. That was the threshold used for the Radiance trials using the ultrasound catheter system until further evidence becomes available. Now that's just one example showing that renal denervation does lower blood pressure. That's 24-hour systolic blood pressure across all sham-controlled renal denervation trials. Most prominently, probably the Simplicity HM3 trial, which did not lower blood pressure, but all well-done sham-controlled trials. Most recently, Bears, which was published yesterday in Circulation, they showed that renal denervation really does lower blood pressure, independent of pharmacokinetics, dynamics, and adherence. So what are my take-home messages from the guideline? Hypertension is still hypertension. There's no need to learn a new definition for hypertension. Out-of-office blood pressure measurements are really recommended, if logistically feasible, to diagnose hypertension and guide blood pressure-lowering medication titration. There's a risk-based approach for patients with elevated blood pressure, considering risk modifiers and sex-specific risk modifiers. In patients with high cardiovascular risk and office blood pressure above 130/80, and after 3 months of lifestyle measures, pharmacotherapy, usually as a monotherapy, is recommended. On-treatment blood pressure target is 120 to 129 and 70/79 for all adults, provided that treatment is well tolerated. And again, that's the ALARA principle, as low as reasonably achievable. And management is tailored considering frailty instead of age. The guidelines recommend up-titrating from a low-dose double to triple combination therapy, preferably as a single pill combination, before up-titrating the dose of a single drug. And renal denervation is a treatment option for resistant hypertension and in certain patients on less than 3 drugs if the patient does want to undergo an invasive procedure. And that's probably one of the most important aspects throughout the guideline. The guidelines emphasize the importance of shared decision-making. We had patient representatives involved in writing the guidelines. There are several communication aids throughout the guidelines helping with the communication with the patient, and there is a version available in a simple language, or will be available for the patients to read. Because we know that patients have better blood pressure control and better outcomes if they're involved in their hypertension management. And last but not least, for hypertension during pregnancy, the threshold was changed. The guidelines recommend drug treatment if blood pressure is above 140/90 and the target is below 140/90, but not below 80 for the diastolic blood pressure. That's just because there's no further evidence available for lower targets. Thank you. I'm happy to discuss the guidelines. I'm sure there's a lot to discuss.
Thank you very much, Lukas, for this great overview on a very prevalent topic, obviously, in clinical practice. Are there questions from the audience? Maybe I'll start with the first one. We were all a little bit, I think, surprised by the new category of elevated blood pressure, and especially about the diastolic part. It says more than 120 or above 70. So already isolated diastolic blood pressure above 70 would be elevated blood pressure.
Yes.
And can you comment on diastolic blood pressure, especially in the lower regions?
Yes, so high diastolic blood pressure is defined as elevated blood pressure, and it's defined as hypertension if it's high enough, but it does not merit pharmacological treatment. We know that isolated diastolic hypertension is very prevalent in patients with metabolic diseases, so we should insist on lifestyle measures to reduce body weight, to minimize alcohol consumption, and to lower blood pressure. but there's no indication for pharmacological therapy in patients with isolated diastolic hypertension or isolated elevated diastolic blood pressure.
So, Lukas, thank you very much for this excellent presentation. Renal denervation is now a class 2A recommendation in a certain kind of patients. It's also stated that patients with a GFR below 40 should not undergo renal denervation, despite there's some data, like registry data and case reports, that patients with kidney disease may especially benefit from renal denervation with regard also to prolongation until they go into dialysis. Could you comment on this contrasting findings?
Yes. So renal denervation is a class 2B recommendation in the new guidelines. We do have data from single-center studies and registries. We have data from single-center studies for very terminal chronic kidney disease, end-stage chronic kidney disease, but those are only single-center studies with a low quality. Those patients are usually hard to treat because the renal arteries are quite small, the kidneys are quite small as well in these very end-stage renal disease patients. So these are not the patients you should start with if you want to start up a renal denervation center. We're still allowed to treat these patients, but in studies. So it's not for clinical practice to treat these patients. We do not have data from sham-controlled trials or randomized trials, but you can obviously treat them in registries because there is an increased sympathetic nerve activity in these patients, and they might be a good target for renal denervation, but it's not recommended for clinical practice.
Well, this elevated blood pressure is difficult. Sprint was already criticized that lowering the blood pressure below 130 systolic increases the patient population significantly. Now we are talking about the patient population which is in between 120 and 130 in addition. And even if you mention that they don't deserve medical treatment, you want them to change their lifestyle. And that means you need to follow up them, because you cannot once tell them, well, change your lifestyle and that's it. So this increases the patient population we have to deal with significantly again. And how should this be done?
Yes. So as you correctly said, there's no need to treat patients with 120 to 130 with medication. But I think one of the most important aspects of the guideline is to prevent hypertension. And I think that's what it's all about. There's no chlorine prevention, but that is reducing cardiovascular events in the long term, preventing hypertension. I do understand that it's difficult logistically to follow up all these patients. The guidelines also state that not all of the hypertension management should be done by physicians, but it's important to have a multidisciplinary team involving specifically trained nurses and for example, pharmacies. But yeah, the workload will increase. Yeah.
Maybe one quick question before we transition to the next presentation. Obesity or adiposity is certainly a risk factor for hypertension. How do you consider the antihypertensive potential of GLP-1 agonists and weight losing drugs?
Yes, so obviously those are good treatment option in patients that are really obese, that have obesity. We know, for example, for bariatric surgery, that patients, even before they lose weight, they have reduction in blood pressure immediately after surgery just because of the changes in the inflammasome. So obviously reducing weight, blood pressure lowering therapies, and obesity therapies are the way to go probably in the future. And yeah.
Thank you so much. I think this was a very important guideline revision of one of the most important risk factors in cardiovascular medicine. So thank you so much. And we transition now to the topic of peripheral vascular disease and aortic disease. And it's a pleasure to introduce Thomas Zeller from Bad Krotzingen.
Well, thank you for the invitation. I had to shorten my presentation in terms of focusing on peripheral artery disease because the guidelines are written in a volume of more than 170 pages and according slides. So who is involved in these guidelines? Similar to the hypertension guidelines, it's a
limited number of societies endorsing these new guidelines. Opposite to the 2017 guidelines, the European Society for Vascular Surgery is not anymore involved into those guidelines, so they will publish their own ones. And this is the task force. Unfortunately, I was a little bit disappointed about that only 2 of those names mentioned over here have really high level of interventional experience, what may have impacted also the wording of these recommendations. I can skip these slides because everybody is aware of it. So for me it was interesting to see this slide. It shows you the prevalence per year of peripheral artery disease, and it does not reflect daily reality, because you can see that women are more likely to suffer from peripheral artery disease than male. Clinical reality is the opposite. We are dealing more with male patients than with female patients. And same as already mentioned for the hypertension guidelines, we have the classical risk factors for atherosclerosis, but they are now supplemented by other ones, sex-specific guidelines, socioeconomic risk factors, and so on. So we have to broaden our view on our patients coming to our institutions asking for treatment for peripheral artery disease. So I would like to start at the level of the head. So what is a high-risk population for carotid artery stenosis? It's a patient population in an age of more than 60 years with classical risk factors including hypertension, coronary artery disease, current smoking, and first-degree family history of stroke. So family history is very important in peripheral artery disease in general. And you can see if patient is at the age of more than 60 and has 4 of the classical risk factors, he has a 67% likelihood to have or to experience a carotid artery stenosis. Another risk factor is neck irradiation. Very important because this is one of the reasons or causes of carotid artery stenosis, which is then an indication for interventional procedure. If you look into the new recommendations regarding diagnosis of carotid artery stenosis, first-line modality is duplex ultrasound, and it should be measured the degree of severity using the NASCET method and not the ECST method. What's the difference? ECST is using the local dimension and the distal, the local dimension, and this overestimates the degree of stenosis significantly. So if you read papers, usually the degree of carotid artery stenosis is given as a NASCET diameter stenosis. What about patients with symptomatic carotid artery stenosis and drug treatment? If these patients are not undergoing revascularization immediately, it's recommended to give them dual antiplatelet therapy for 3 weeks, and this is then followed usually by single antiplatelet therapy as a standard of care. What is if we are dealing with asymptomatic carotid artery stenosis? The guidelines are very conservative in indicating interventional procedures, meaning revascularization. So best medical treatment has become the standard, and it's important to analyze the life expectancy of those patients if it's more than 5 years, and the revascularization procedure has a risk of less than 3%, then you can consider to recommend a revascularization procedure. In all other occasions, medical or best medical treatment is the primary treatment. What is a high-risk feature for stroke? What qualifies patients at a high risk? It's clinically the collateral tear or stroke event in the past. It's an ipsilateral silent infarction in MR, for example, and it's a stenosis progression. These factors are accepted as high-risk factors, qualifying patients for a revascularization procedure today. What are high-risk perioperative features for carotid endarterectomy? It's the overall patient condition, including congestive heart failure. It's unstable angina. It's coronary artery disease, including the left main. It's recent MI. So more or less, it's cardiac disease. If these patients have concomitant cardiac disease, they are not qualifying for endarterectomy as the primary revascularization measure. They should more likely undergo stent implantation. Still, surgery is recommended as first-line revascularization modality if the periprocedural risk is less than 6%, different to the US guidelines, which mention stent implantation as viable alternative to carotid endarterectomy. Stent placement is recommended even in the new guidelines today as a second choice for treating symptomatic carotid artery stenosis. How to deal with patients after stent implantation? It's dual antiplatelet therapy for at least 1 month. The new stent devices, double layer mesh stents, micro mesh stents, they deserve dual antiplatelet treatment for 3 months. This is the algorithm for carotid artery stenosis management. You can see duplex ultrasound is the first line diagnostic tool. Only if duplex is not conclusive, CT, in particular CT angiography, is the second choice for diagnosing the degree of or the severity of carotid artery stenosis. Optimal medical therapy is a class 1 recommendation for each kind or severity of a carotid artery stenosis. And the vascular team, including a neurologist, should discuss a potential revascularization procedure if a patient is at high risk for stroke. These are the recommendations for symptomatic patients. Again, duplex ultrasound as screening method, followed by CT or MR. That's important for planning the revascularization procedure, not only for the surgeon, but also for the endovascular specialist. And irrespective of revascularization, again, best medical treatment, which is similar to the recommendations in cardiology, is the basic treatment. And revascularization should be offered to those patients within 21 days following the first symptoms in every kind of carotid artery stenosis between 70 and 99%. If a patient is coming with acute stroke, total occlusion of carotid artery is also an indication. If it's longer than 1 day ago, the revascularization is not recommended. Upper extremity artery disease, there is not many new recommendations published, only that if patients are known for atherosclerotic disease, bilateral arm blood pressure measurement is recommended for all those patients. Endovascular revascularization may be considered over surgery because it's simply less invasive, and routine revascularization in patients with atherosclerotic subclavian artery disease is not recommended. So the patient needs to be symptomatic or needs potentially to undergo coronary artery bypass surgery, including the mammarian artery. What about renal artery and mesenteric? Again, duplex ultrasound is the first line imaging modality to screen for renal artery stenosis. And this slide can be easily summarized. Today, the indication is becoming a little bit more liberal for revascularization of renal artery stenosis. In case of bilateral, more than 70% renal artery stenosis, or single kidney artery stenosis, there's a clear indication. It's 2A class recommendation for revascularization, which today is stent angioplasty. It depends a little bit on patient symptoms. In unilateral artery stenosis, if patient is uncontrolled with hypertension or shows an increase in creatinine, a decrease in GFR, it's also an indication. But not every unilateral renal artery stenosis should undergo revascularization. This is a little bit strange, this part of the algorithm screen here. The recommendation, more than 70% renal artery stenosis may undergo revascularization, or hemodynamically relevant 50 to 70% renal artery stenosis. If you look into the literature, less than 70% diameter stenosis does not result into hemodynamic changes, so this is a little bit nonsense. Mesenteric artery disease, there is one new recommendation regarding acute mesenteric ischemia. It's recommended to evaluate those patients by a vascular team. I would say the general surgeon and the anesthesiologist is or should be also part of the team, in particular in acute mesenteric ischemia. In chronic mesenteric symptomatic ischemia, stent angioplasty is the method that should be offered to our patients. I will skip this and come finally to lower extremity artery disease. Screening. When managing patients with peripheral artery disease or aortic disease, it is recommended to adopt a comprehensive approach that addresses the entire or the entirety of arterial circulation. What does that mean? If a patient is coming with peripheral artery disease or with an aortic aneurysm, for example, he should be evaluated for other areas of atherosclerosis manifestation. And in addition, he should at least undergo a stress test, a cardiac stress test, in order to exclude a significant coronary artery disease. Why that? If you look here into patients with peripheral artery disease, there's a very high likelihood that these patients also present with coronary artery disease, and therefore at least once a screening at the beginning of their PED career should be indicated. Why is it important? Patients with peripheral artery disease are at the highest risk to experience cardiovascular events. It's 4 to 5 times higher than in a population without peripheral artery disease. So screening for coronary artery disease is really mandatory in this patient population. Physical activity, to make it short, it should be supervised either in a exercise group, in a hospital, or in a sports club. Walking is clearly the preferred exercise, even if every kind of physical activity is beneficial for the overall patient's condition, but walking is the best to improve claudication. This is again highlighted here. Exercise training results in improvement of symptoms and increase in quality of life, and it is important for elderly patients because it improves also the functional status and the walking performance overall in these patients. What is the optimal medical treatment? Of course, it's smoking cessation, it's reducing high blood pressure, it's cholesterol lowering, and optimizing blood glucose control. There are exactly the same guidelines and cutoff values regarding the lipid levels, in particular LDL cholesterol level. This is new in this year's guidelines. It was also reduced to less than 55 milligram per deciliter. In the older guidelines, it was still 70 milligram per deciliter. I will skip that. If we come to antihypertensive therapy, the recommendations are again based on the SPRINT trial outcomes. So it's less than 130 over 80 millimeter mercury, and anti-thrombotic therapy. There's a new kit on the block, which is not standard in coronary artery disease prevention or post-interventional treatment. There are two large randomized controlled trials evaluating the value of low-dose rivaroxaban. The one is the COMPASS trial, which evaluated patients with peripheral artery disease treated conservatively in a randomized controlled, placebo-controlled fashion. They either received aspirin plus rivaroxaban or aspirin plus placebo, and there was a significant decrease in cardiovascular and limb events, and the same was found in post-procedure and post-surgical patients. Again, significant lower cardiovascular and limb events if patients did receive rivaroxaban 2.5 milligram 2 times in addition to aspirin. What is about patients needing oral anticoagulation, for example, because of atrial fibrillation? The recommendation is to continue, of course, oral anticoagulation supplemented by a monotherapy with either aspirin or clopidogrel. After revascularization, the recommendation is not very strict. It's still not supported by a lot of evidence how to deal with these patients. It depends in daily practice how patients had been treated interventionally, whether drug-coated devices had been used. If so, the dual antiplatelet therapy usually lasts 3 months. If only plain balloon angioplasty or bare metal stents are used, it's a recommendation for 4 weeks. Indication for revascularization should only be discussed with the patient if he is undergoing a 3-month period of supervised exercise therapy. That's not very practical, to be honest. And if endovascular therapy is indicated, then drug-eluting treatment should be considered as the first choice strategy in femoral-popliteal lesions below the knee. We don't have this large evidence as compared to above the knee. There's a little bit not realistic recommendation now included into these new guidelines. Reading in femoral-popliteal lesions, if revascularization is indicated, an open surgical approach should be considered when autologous vein is available in patients with low surgical risk. This will include even stenotic lesions. This will include an occlusion of 2 or 3 centimeters that can be managed easily by endovascular means. So this recommendation is, in my opinion, complete nonsense. This should be considered venous bypass graft if it's a complex femoral-popliteal lesion, but not in every patient with symptomatic femoral-popliteal disease. Then regarding the intervention, and I will stop after this with this presentation. If we are dealing with femoral-popliteal revascularization, there's a weak but relevant recommendation to evaluate the outflow, and if the outflow, meaning the BTK arteries, are also diseased, to tackle these outflow lesions, because there are some data in the meantime available that improving outflow may also improve the durability of the primary endovascular femopopliteal revascularization. Thank you very much for your attendance.
Thank you very much for this overview and on an extensive guideline, and perhaps also reflecting some personal flavor on the interpretation of some. We have time for a short discussion. Maybe I kick off. So if patient is identified with carotid artery stenosis or peripheral artery stenosis, what are the recommendations or your personal recommendation in terms of screening other vasculatory territories, and how should we assess for the presence of coronary artery disease?
Well, the easiest way to examine the patient is physical examination. It's pulse palpation. That's the first step, of course. So if a patient with carotid artery stenosis, with coronary artery disease, is coming to you in your practice, in your clinic, you should at least measure blood pressure at both arms, and you should palpate the ankle pulses. If they are not present, then you can simply perform an ABI measurement. So that's the routine screening for upper and lower extremity peripheral artery disease. And in addition, in male patients older than 60 years of age, you should also perform a duplex ultrasound of the aorta in order to identify an aortic aneurysm.
I think certainly also room for improving medical treatment. I'm pleased to see that the LDL thresholds have been adapted to what is recommended in the coronary artery field, that is less than 1.4, and I think we need to be aware that many patients don't reach these targets. Maybe one question shortly to the issue of antithrombotic therapy. At least what I still see frequently in practice is the combination of antiplatelet therapy and oral anticoagulation in patients with atrial fibrillation. Now the AF guidelines clearly mark this as a class 3 issue. I think it's also carefully avoided, mentioned here. But there remains this presence of this dual antithrombotic therapy. So how can we enforce that actually the antiplatelet therapy is removed in these patients?
The problem is that we don't have any data justifying either leaving antithrombotic medication away in patients with indication for oral anticoagulation. There is only data, for example, for post-operative management following bypass surgery, comparing, for example, aspirin with oral anticoagulation. But oral anticoagulation in this study was full anticoagulation, so it was an INR of more than 3. If we are talking about oral anticoagulation in patients with AFib, then we are with a kind of intermediate anticoagulation. It's not effective. It's not an effective anticoagulation, and nobody knows if this is preventive for the occurrence of local thrombotic events in the presence of peripheral artery disease. Even if we don't know if adding aspirin or clopidogrel does reduce the risk. So simply there is no data. There's absolutely no data for recommending the one or the other.
I have a question regarding carotid artery disease. You showed that we need to make the distinction between symptomatic and asymptomatic carotid artery disease. And maybe sometimes that distinction is not so easy to make. And I ask this question because if you make an MRI in patients that are between 70 and 80 with some risk factors, you might find a lot of also silent ischemic lesions. Are these now called symptomatic, or are they asymptomatic? How do you make the distinction?
Yeah, well, they do not qualify if they are silent. Per definition, these patients are asymptomatic. Well, for classifying as a symptomatic patient, the patient has to have symptoms of a stroke, And if they are not present, the patient per definition is still asymptomatic. But if you detect silent former ipsilateral strokes in the presence of a high-grade carotid artery stenosis, this increases the level of risk for this patient, and you should consider revascularization in these patients. You should discuss this patient with a neurologist, and you should evaluate the overall patient condition, life expectancy, and so on. Because with asymptomatic carotid artery stenosis, data showing that there is a benefit of revascularization are based on a life expectancy of at least 5 years, and that's why it's mentioned in the guidelines. So if a male patient is 85 years of age, for example, per definition, he has not anymore a life expectancy of 90 years, of another 5 years. Yeah. So.
Thank you very much. I think in the interest of time, we conclude this session. And directly move over to the next session. And the next speaker will be Christine Meyer-Zürn. And Felix, you could also join the panel at the front.
So
please, Christine.
Yeah, Misha, thank you very much for the kind introduction. I'm very happy to present you data on women's health in cardiology. And after my talk, I think I have convinced you that the future of cardiovascular medicine in women has already begun. So what is the current knowledge on sex differences in cardiovascular diseases? We see differences in pathogenesis, epidemiology, treatment, and outcomes. And this is due to the fact that women with cardiovascular diseases are much older than men, because when they get into menopause, they lose the protective effect of their estrogen levels. When they're older with cardiovascular diseases, they also have more comorbidities and or more risk factors. That's why they're more risk people compared to men. In general, we know that there are like the specific classical risk factors like smoking, hypertension, etc. But in females, we know that also other risk factors are present, such as autoimmune disease, such as depression, such as pregnancy-related complications. So we have another risk profile. Sadly, the awareness about cardiovascular diseases in women is low, both in the healthcare providers and also in the women themselves. That's why the current guidelines currently don't differentiate between men and women. We have the same identical guidelines, and this is due to the fact that the data we now have, they come from sub-analysis from RCTs, or only from sub-analysis that are not even powered to detect the differences, or from registries. And in general, women are underrepresented in cardiovascular trials. That's why it's correct that we don't distinguish between men and women in the trials, and we don't have a differential treatment for men and women yet. But if we would get more prospective randomized controlled trials, and I will present you one today, and more adequately powered secondary analysis of RCTs, then perhaps in the future we could have sex-based, gender-based clinical guidelines from the ESC. So I want to give you some examples about sex differences in cardiovascular diseases. For example, ischemic heart disease. Women more often suffer from microvascular disease, and when they have an acute coronary syndrome, data show that they are less likely to undergo a timely revascularization in angiogram, and also less likely to get rehab. In STEMI patients, there's even a mortality gap with a negative outcome for women. With regard to atrial fibrillation, women are 1 decade older when they are diagnosed with atrial fibrillation. They have more asymptomatic symptoms, atypical symptoms, and they are also less likely to undergo PVI and electrocardioversion. If they undergo it, the recurrence of AF is more common in women. Perhaps in the future, the PFA trials show that this gender gap perhaps gets attenuated in atrial fibrillation. With regard to heart failure, we all know that HFpEF is more present in women in comparison to men. We also see some differential effects of medication. For example, there could be a better benefit from sacubitril/valsartan in women,
And we have a higher response rate to CRT, but women are less likely to get CRT. With regard to hypertension, Lukas Lauder already showed you that women have a steeper increase in blood pressure from their 30s on, and that cardiovascular complications start already at lower blood pressure levels in women. Furthermore, they have more side effects from antihypertensive treatments. Therefore, also the adherence to blood pressure medication is lower, and we see a worse blood pressure control in women compared to men. Vascular disease, Professor Zeller already showed us peripheral artery disease. It is underdiagnosed in women, and we also have sex differences in stroke and a striking increase in vascular dementia in women more than in men. Of course, cardiovascular disease in pregnancy, peripartum cardiomyopathy is a topic only for women. And Takotsubo syndrome is also a disease that is more prevalent in women. So now I come to the topic of the RCT, which I will show you now, valvular heart disease. With regard to rheumatic heart disease, we see that women in the younger age in developing countries have a higher prevalence of rheumatic heart disease. But we also have some data that there's a different effect of surgical versus transcatheter aortic valve replacement in men and women. And the first RCT in cardiology that was only performed in women was presented at the ESC on August 31. It's the RHEA trial, randomized research in women, all comers with aortic stenosis. And this trial tests transcatheter versus surgical aortic valve replacement in women. It's a French study. Why is this even important? As you can see here, the prevalence of calcified aortic valve disease is equal in men and women, so it's a relevant topic also for women. And when people get older, even more women have aortic stenosis and they have a higher life expectancy, so this is a very relevant topic. Despite this, we know that the rates of intervention of the aortic valve is less in women compared to men, and this is both for surgical and for TAVI. And there are some female-specific issues in TAVI. For example, we have small vessels in women, we have a small aortic root, we have small ventricles, we have more hypertrophy in women, and we have the longer life expectancy of women. So the background of RHEA, recent data from the partner trial, sub-analysis, they have suggested that the risk of a mortality after surgical aortic valve replacement is higher in women, but the benefit following TAVI is better in women. However, as I already told you, women are underrepresented in the clinical trials, also, of course, in the low-risk TAVI versus surgery trials. Therefore, a RCT was necessary to confirm the benefit of TAVI over surgery in women. The purpose of RHEA was to compare the outcome of TAVI with a balloon expandable valve versus conventional surgery in women all-comers with severe symptomatic aortic stenosis. It was an investigator-initiated multi-center international RCT. It was performed in Europe in 48 clinical sites, 12 countries, and women were randomized 1-to-1 to TAVI with SAPIEN 3 or SAPIEN 3 Ultra versus surgery with any commercially available surgical valve. The primary endpoint of the study was the composite at 1 year after procedure. That was all-cause mortality, all stroke, and rehospitalization. Inclusion criteria of the study were women with a severe symptomatic aortic stenosis if they had a traditional classical high gradient aortic stenosis, or if they had a low gradient but severe aortic stenosis that was confirmed by stress echocardiography. Every patient was discussed in the heart team. Exclusion criteria: bicuspid valves, unicuspid valves, non-calcified aortic valves, complex coronary artery disease, and other anatomical features. So between November 2019 and March 23, 490 patients were screened. Eventually, the procedure TAVI was intended in 221 patients and surgery in 222 patients. Excluded before the treatment in the TAVI group were 6 patients for reasons like withdrawal of consent or exclusion criteria that were detected afterwards or refused of the intervention. And in the surgery group, there were 17 patients before treatment excluded, mostly because the patient didn't want to go operation or also because the physician decided TAVI would be better. So we remained with 215 patients in the TAVI group and 205 patients in the surgery group. In the TAVI group, 3 conversions to surgery were necessary due to complications, and 2 conversions to TAVI were also done in the surgery group. The 30-day follow-up and the 1-year follow-up was very good, complete with numbers more than 96%. If we look at the patient baseline characteristics of the women, we see that they were in the age of 73. They were low-risk patients with an STS score of a mean of 2. They had a rate of coronary artery disease of 19%, diabetics 26%. So the baseline characteristics were well balanced between both groups. We had atrial fibrillation 5 and 3% before the procedure, and we had an aortic valve area of 0.8. We had a mean gradient of 47, so the high gradient aortic stenosis was the predominant part of that study cohort. We had a good left ventricular ejection fraction of 66, and 70 and 75% of the patients had a small annulus, as we see often in women. So the procedural findings, SAPIEN 3 and SAPIEN 3 Ultra were used, as I told you already. Concomitant procedures were only 1 planned pacemaker implantation in the TAVI group. You see that the majority of patients had a 23 millimeter valve in the TAVI group. In the surgery group, Edwards Magna Ease was the predominantly used valve, and full sternotomy was also used in the majority of patients. However, we had more concomitant procedures like a CABG, 6.8%, or also surgery for atrial fibrillation, but no aortic annulus enlargement despite small annuli. You see that the valves size that have been used for surgery are a little smaller. We have 23 millimeter in 43% of patients, and we also have 11 and 34% using 19 or 20 millimeter valves. So the procedural complications, there was 1 intra-hospital death in the TAVI group and 1 death also in the surgery group. We had 1 aortic dissection noticed in the group, and coronary obstruction was also noticed in 1 patient of the TAVI group. So the rate was similar for both groups on a statistical level. When we see the primary endpoint, the composite of death, stroke, rehospitalization after 1 year, they saw a rate of 15% in the surgery group, and the TAVI group had a 2-fold lower incidence of this primary endpoint with 8.9%. And this means that the non-inferior criteria was met, but as the study was also powered to show superiority, this was also met by statistical analysis. If we look at the components of the primary endpoint, we see the death rate was low, 2% in the surgery arm within 1 year and 1% in the TAVI arm. We see that stroke rates were similar between the TAVI group and the surgery group. And the driver of the positive primary endpoint was the rehospitalizations due to valve problems, procedure problems, or also due to worsening heart failure. And there we see that in the TAVI group it was 4.8 of patients, but in the surgery group it was 11.4 of patients. So that was the significant difference driving the difference in the primary endpoint. When we look at key secondary endpoints, there were statistically significant differences in the rate of new pacemaker implantations, as expected in the TAVI group, 8.8%. And, which I think is very interesting, they saw a higher rate of new NSAID atrial fibrillation with 28% in the surgery group, but only 3% in the TAVI group. And as we know, and we have already had a lot of data that post-operative atrial fibrillation after cardiac surgery can be associated with worse outcomes. This is, of course, a relevant finding, and this can have contributed also to the higher rate of rehospitalization in the surgery group within 1 year. When we look at other secondary endpoints, the number of patients discharged home, directly discharged home and not needing rehab, was higher in the TAVI group compared to the surgery group. And of course, also the median index hospitalization stay was lower in the TAVI group with 4 versus 9 days. With regard to quality of life, on the right part, you can see that, of course, quality of life was better initially in the TAVI group because that's a less invasive procedure and patients were feeling better within 30 days. But after 1 year, there was no significant difference in the quality of life between the TAVI arm and the surgery arm. When we look at echocardiography, the hemodynamics of the valves implanted by the surgeons or by the TAVI team was excellent. There was slightly better gradients and a better aortic valve area in the surgery arm, but in total, the mean gradients were reduced from 47 to 12, and the valve area was going up from 0.8 to 1.8. Despite a small annulus of 70% of the females, the incidence of a severe patient-prosthesis mismatch was low in both groups, and it was also not statistically significant after 1 year. The rate of mild paravalvular aortic regurgitation was higher in the TAVI arm as expected, but there was a very low rate of moderate paravalvular aortic regurgitation and no severe paravalvular aortic regurgitation. So the authors of RHEA concluded that in women all comers with severe aortic stenosis, TAVI using the SAPIEN 3 or SAPIEN 3 Ultra was superior to surgery for the primary composite outcome of death, stroke, and rehospitalization at 1 year. And the superiority was driven by the lower rates of rehospitalizations in the TAVI group. TAVI had a lower incidence of new onset atrial fibrillation after 30 days and after 1 year. Patients had a quicker recovery and a shorter length of hospital stay, but they had higher rates of mild paravalvular aortic regurgitation, which is not completely but irrelevant, but moderate and severe was not a problem. And they had a new permanent pacemaker implantation rate that was higher than the surgery group. We can say that excellent hemodynamics were achieved in both procedures, both with TAVI and with surgery. And besides the benefit that the patients experience, the TAVI treatment also provides benefits in terms of the healthcare. As we have seen that the hospitalization rate was shorter, the rehospitalization rate was lower, and more patients were able to be discharged directly home. Limitations of the study are the limited sample size, of course. On the other hand, the study was powered to show superiority. Then women with unicuspid, bicuspid, or non-calcified valves were excluded. And the recruitment period of the study was relatively long, with 3.5 years, and this was due to the COVID pandemic. Concomitant procedures, I have showed you that they were done in a higher percentage in the surgery group with CABG, for example. And of course, we cannot extrapolate the finding to other valve types. So the key takeaways from RHEA and from the Women in Cardiology topic of my talk is that in women with symptomatic severe aortic stenosis, TAVI using a balloon expandable device could be considered the preferred therapy. And we also see that in patients that will not undergo TAVI, surgery is a very good option in these patients, also showing excellent results. In general, the underdiagnosis and the undertreatment remain the biggest risk for women with aortic stenosis. We have effective therapies, but we have to get our patient to receive these therapies. And it's also the same for other cardiovascular diseases where underdiagnosis and undertreatment is present in females. So it is important for us to close the gender gap. I'm pretty convinced that more cardiovascular RCTs only in women or adequately powered to show sex differences will come in the future. Thank you very much for your attention.
Christine, thank you very much for this excellent overview and your talk. I have only one question. Would you change your clinical practice after seeing this study?
Yes, so we have to say that in the RHEA study is the first randomized trial. It's 400 patients, so it's not that we have so much data now. But what we can say is that they saw that patients that were even below the age cutoff of 75, they were 73 years old, that these women benefited from TAVI with regard to rehospitalizations, which is very important for this patient cohort, I think. So we decide on every TAVI, of course, in the heart team. But I think like the knowledge of this study perhaps will also influence us saying that, okay, even perhaps women at a cutoff that is like in between, we could say that we prefer TAVI. But of course, we don't have any guidelines now, but this is, I think, a beginning of a good study showing differential results in TAVI patients in women.
Thank you. Any other questions from the audience?
Probably I have one. Christina, thank you very much for the great presentation. You highlighted in very detail how important it is to look more into female patients. You said at the beginning that the prevalence for aortic stenosis is similar in men and women, but you also told us that TAVI or also SAVR is more often performed in men. So I think that's a very important point to highlight, that we have to look into female patients much more to identify those with severe aortic stenosis and send them for treatment.
Yes.
Because you showed very, very nicely that these patients, 73 years old, young patients in a TAVI cohort with a very low surgical risk. The SDS score was about 2.
Yes.
Yeah. So very, very low risk patients who really benefited from the treatment in both groups, but with superior outcomes in the TAVI group.
Yeah.
So what do you think about patients nowadays? We just heard the guidelines currently recommend 75 years, the cutoff. What do you think about contemporary treatment in these patients when you think about the differences in anatomy? You said that patients, female patients have more often a smaller annulus, smaller arteries in the groin. What do you think was the reason that the surgical group had smaller valves implanted, giving them a higher risk for patient-prosthesis mismatch? Because the current guidelines recommend a root enlargement, but you said it was not performed.
0%, yeah. This was also discussed at the ESC. So they suggested that the surgeons perhaps did not have such a good CT planning of the valve before the patient underwent surgery. So in TAVI we have the CTs where we really directly see and measure in detail the annulus, and so perhaps this was one reason. And also like that, perhaps it was also like a surgical problem, like if you do enlargements of the annulus, that also takes longer, of course. And so it's not in favor, of course, of the patients if they get 19 or 20 millimeter valves. Now we had excellent results with the gradients equal in both groups, but we don't know in the long term if we see like in 5 years and the women are not so old. So if they come back in 5 or 10 years, we don't know what happens to these 20 meter valves that were implanted in the study in the surgery group. And it's also questionable if then we could offer like a TAVI in such a small valve.
I heard that argument that the surgeon said the CTs that they performed were non-diagnostic and they were not sufficient enough to guide their procedure, which I found a little difficult to follow because patients were randomized post-CT scan. So we used, or the interventionalists used the same CT scan as the surgeon. So I wonder, and we have surgeons in the room, so I would be very happy to hear some thoughts. What's the reason? Why are the valves through all studies almost much smaller in the surgical arm as compared to the interventional arm?
Yeah, I mean, that's a very good comment. I think one thing is when you look at the profile of the valves, the TAVI valves are much less low profile. So you get more opening area you have a very thin material, so you got a lot of area for the opening. With regard to the CT scan, what's the difference with surgical valves and TAVI valves is you plan in advance based on your CT scan. We plan in the OR when we put in our sizes. So this is something that we need to change in the future. And that's something some centers are working on, that we say, okay, we look at our patients afterwards and see, okay, based on the annulus size that we had in our CT scan, which valves did we get in? And you don't always get in the same valve size. So for example, sutureless valves, you get in sometimes a bigger valve than with a sutured valve. So then you have the risk of coronary obstruction, where some surgeons also will use a smaller valve to avoid this risk. So I think it's a multifactorial topic, and I think it's good that we have this study, and I was really astonished that the gradients were comparable, although there was a 19 and 20 meter valves. But I think we shouldn't implant those 90 millimeter valves anymore, but as long as they're in the market, there will be surgeons who implant them. And I think there are some patients who will benefit from 90 millimeter valve if you don't have to do any root enlargement, but this is a very, very small minority and should really be reserved for bailout situations where you say, okay, I cannot do anything more. But I agree with you, we need to implant larger valves, 23 at minimum, and also try to anticipate which valve size can I get in, that we also schedule the patient for the right surgeon. So let's say a resident shouldn't, this is not a resident case because I need a root enlargement, if you can plan already in advance. And this is something that we need as surgeons need to learn from cardiologists to anticipate already where are the problems and which size can I get in.
Okay, thank you very much again, Christine, for your excellent lecture. And we move on with the next topic, certainly also a hot topic during ESC Congress, and I would say a whole year long we're talking more and more about cardiometabolics, and I'm very happy to have Professor Ottmar Pfister with us, who's running our prevention and heart failure program here at University in Basel. And Ottmar will discuss with us the greatest and latest from cardiometabolics. Ottmar.
Thank you very much, Felix. Welcome here, and ladies and gentlemen, I talk about cardiometabolics, and if we talk about cardiometabolics, I think we have to talk about obesity, because this is the main driver, I think, in this condition. Because as you all know, obesity is really clustering all the cardiac risk factors, the traditional cardiac risk factors, and is leading therefore to more atherosclerosis, to more heart failure, to arrhythmias, AFib, thromboembolic problems, and even valvular heart disease. And unfortunately, as you can see on the left side, we have a high mortality in this patient population with a BMI of 30 because of cardiovascular disease. And if we look at the definition, maybe for us cardiologists, it's sometimes good to see what is obesity. Obesity is when the BMI is above 30, it's class 1. Above 35, it's class 2. And above 40, it's class 3. Sorry. If you look at the prevalence here in Europe, you see here the map. In average, we have a prevalence of about 20 to 25% of persons with obesity here in Europe, but you can see some green spots, and you can see that Switzerland is green. So we are still on the low side, meaning a prevalence of about 19.7%. Obesity is not only BMI, there are different phenotypes, of course, and you'll know that the abdominal phenotype of obesity is the most dangerous one, because you have this visceral fat, and these free fatty acids here in this condition are not buffered by the subcutaneous fat in this condition, and it's accumulating in the belly and also in the organs like the liver, in the heart, in the epicardium, in the pericardium, in the kidney, and so forth. And that's why this phenotype has an increased cardiovascular disease risk, and of course an increased risk in diabetes. So how can we assess more accurately cardiometabolic risk in clinical practice beside BMI? So there are some clinical metrics we can use here. As you know, the waist circumference, we should measure that in our patients. So if you're a male and your waist circumference is above 95, you should worry a little bit. If you're a female, it's 85. And then you should measure also triglycerides, because then with these two measurements, you have the so-called hypertriglyceridemic waist. And if these numbers are elevated, it's somehow a predictor for visceral fat. Of course, we can use imaging methods to really see and measure and quantify fat in the body. We have the DEXA scan, that it's something that we use in research, but of course we have MRI and CT, and you see here one example of an MRI, a BMI of 25. This is not obese, but you can see a lot of fat in the belly. And this is a person with BMI of 30, but a lot of muscle mass and less fat in the belly. So you can guess which one of them has the higher cardiovascular risk. Interestingly, the CT, I think, is very good to see the epi and pericardial fat, and maybe in the future we do more and more coronary CT, and so we can also measure these fat depots in the body, so like a one-stop shop method. So what are we doing against this obesity syndrome and cardiometabolic problems? So first of all, it's diet and exercise. This is the first thing, and we have good data here from the Look Ahead study. It's more than 10 years ago. I think it was an important study because it randomized patients with diabetes and obesity to an exercise group and diet group and the control group, and interestingly followed these patients 10 years. And what the study shows is that you're able to reduce your body weight by 8% following this diet and exercise, but the diet is strict. It's less than, so a reduction of 500 to 800 kilocalories per day. It's a strict diet. But what you can also see, and I think this is reality, so the rebound after a few years, and after 10 years, the difference between the intervention group and the control group was only 3%. The same was with waist circumference, and the reason was, of course, patients didn't stick here to the regimen. It's hard to stick to that for 10 years. For some people it works, but for many people this works not, and that's why the new GLP-1 agonists are a blessing for many patients to really reduce weight and maintain the body weight. So, you know, these agents, they were published everywhere, but you don't know maybe that they have a lot of different direct and indirect actions. So they are cardioprotective, they are renal protective, they lower the blood pressure, of course they lower body weight, but they also lower inflammation, lower glucose, they lower lipids, and so they somehow address the whole problem of cardiometabolic problems in a patient. So there are many studies, as I said, with these compounds in diabetic patients, in obese patients, but I think for us interested in cardiovascular medicine, this is really the trial to look at. This is the SELECT trial. In this trial, patients without diabetes were included. These were obese patients with BMI above 27. They had to have established cardiovascular disease. Most of them had myocardial infarctions, and as I say, no diabetes. The follow-up was 4 years, and as you can see here, the treatment with semaglutide once-weekly injections reduced the MACE endpoint by 20% over these 4 years. Also, total mortality was reduced in this trial by 10%. And you can see body weight was decreased by 8%. And Stefan asked before, does the GLP-1 agonist treatment is lowering blood pressure? Yes, it does. 3.3 millimeter mercury here in this trial of blood pressure lowering. Also very important, lowering of CRP and triglycerides, really pointing that the therapy acts at the core of the cardiometabolic syndrome. But there is one thing to recognize, it's the discontinuation rate. It's a little bit higher in the treatment group than in the placebo group. There was 8% of patients more in the treatment group, and mainly because of gastrointestinal problems.
There is also another very important trial here in this field for cardiovascular prevention. This is a trial in chronic kidney disease. Patients with chronic kidney disease, with albuminuria, with diabetes. Obesity or the BMI was not an inclusion criteria, but as you can see here, the average BMI in this patient population was 32. And these are patients with a very, very high cardiovascular risk. And as you can see, the primary endpoint, of course, it was a kidney endpoint because this was a kidney study, was decreased by 24%. But for us, more importantly, the cardiovascular mortality could be decreased by almost 30%. And also in this trial, total mortality could be decreased by 20%. What about heart failure patients? We know that heart failure and obesity goes together, especially in the HFpEF phenotype. And this is a very elegant analysis from the TopCat study where they showed that this HFpEF obese phenotype has a bad prognosis compared to patients with heart failure with preserved ejection fraction without overweight. It has also a particular gene signature that points towards the cardiometabolic syndrome. And exactly 1 year ago at the ESC, the first heart failure trial with GLP-1 agonist was presented, the STEP-HFpEF trial, where semaglutide was tested in 500 plus patients. And the endpoints were quality of life and a change in 6-minute walk test. The study was not powered for outcomes, but these endpoints, quality of life and 6-minute walk, were clearly met. And again, the patient had around 10% weight loss in this study. But now, interestingly, 1 year later at this year's ESC and published at the same time in The Lancet, there was this very important, in my view, patient-level pooled meta-analysis of all the data that we have so far of this GLP-1 agonist treatment in patients with heart failure with preserved ejection fraction. So the SELECT population is included here. There are about 4,000 plus patients that were heart failure patients with HFpEF in this population. Then the FLOW that I mentioned, and then there are the 2 trials that are that have recruited only heart failure patients, STEP-HFpEF and STEP-HFpEF in diabetes patients. So altogether, this is a population of more than 3,700 patients randomized to semaglutide or placebo. The average age was 64, almost 40% females. Also importantly, these were really HFpEF patients because the ejection fraction was above 50% in 85% of the patients. They were obese and 1/4 of the patients had diabetes. And as you can see, the primary endpoint here in this analysis was also met. Cardiovascular death or worsening heart failure decreased by 30%. And this decrease was mainly driven by a decrease of 40% in worsening heart failure events. It's important, it's not hospitalizations, it's events, but nevertheless, it's an important outcome. In the meta-analysis, there was no signal that mortality was decreased. This is a little bit in contrast to the trials SELECT and FLOW, but these trials have included more patients with atherosclerotic disease and cardiovascular disease like myocardial infarctions, and maybe they were at higher risk. So maybe it's important to also say a word about what the therapy does to the body composition. And there's a very nice analysis published in the New England Journal 3 years ago where they looked at the body composition with this DEXA scan. And they could show here that under treatment with GLP-1 agonist, you lose 60% fat mass, but you also lose, and I think this is very important, lean body mass, almost 40%, 30 to 40% lean body mass. And I think this is important if you have a cachectic and catabolic patient, or if you have a patient with reduced ejection fraction. So you don't want to lose lean body mass. And it's important because these patients have to have exercise training program with resistance training together with their therapy. This is also important, this combination between exercise training and the GLP-1 agonist therapy, because the change in body fat, as shown here in this study with liraglutide, is much greater if you combine these two therapies. And also interesting is that, I don't know whether you know that patients that take GLP-1 agonist, they have a higher resting heart rate. And some patient came to me and said, well, since I take this medication, my heart rate is not 75, it's 85, and I don't know why. And this is something we see also in the studies. And the reason for that is not that clear. There are some basic science data that show that the pacemaker cells in the sinus node have receptors for the GLP-1 agonist. But I want to say that exercise is reducing this increase in heart rate, and is also there, I think, is a benefit. And that's why all the patients, and we do that in Basel, should undergo exercise and an exercise program. So here, just as an overview, what have we at hand today for the treatment of obesity? So the basis is certainly lifestyle modification, diet. So it has to be a strong diet, so less than 500 or 800 kilocalories a day, depends on your body weight, on your activity, of course. Physical activity. Physical activity is extremely important to maintain a healthy weight, also under therapy. And then we have all the pharmacological treatment, mainly the GLP-1 agonist here, semaglutide, where you can achieve a decrease in body weight of around 10%. And there is another one. This is a dual incretin agonist. It's GLP-1 and GIT agonists, the tirzepatide. There are also data coming out. Just recently there was a study published in heart failure patients that showed better quality of life and better exercise capacity under this treatment. With this is a little bit more potent to lose weight. You can expect about 15 to 17% weight loss. And then, of course, for some patients, for selected patients, there is still gastric surgery. It's very good to lose weight. It's also known that your lipids go down and your sugar levels become better, and also diastolic function of the heart gets better after a surgery. But this is only for selected patients. So with that, I would like to give you these take-home messages at home. So we know that abdominal obesity is a cardiometabolic condition with increased cardiovascular mortality and morbidity. Especially the amount of epicardial and pericardial and visceral fat is associated with cardiovascular risk and might be included in risk stratification. We think at the CT maybe this could be something that we can use more. We have very good data that the GLP-1 agonist decreases weight by up to 10% and reducing cardiovascular and total mortality in these patients, not only in diabetes patients, but also in patients without diabetes, and in patients with chronic kidney disease and diabetes. And patients with the obese phenotype of HFpEF, according to this meta-analysis, might experience 40% reduction in heart failure events, not really hospitalizations, but events, I should rather say, when treated with GLP-1 agonists. And GLP-1 agonists, as I said, should be always combined with a structured exercise program in order to avoid loss of lean body weight. That could be loss of muscle, and boost the reduction of visceral fat. Thank you very much for your attention.
Thank you very much, Ottmar. I'm sure there are questions regarding this topic. I start with one probably related to the fact that you also showed, which is always striking me. You know, we see an increase in heart rate, and we know that there is no single therapy in patients with heart failure where we see an increase in heart rate and a reduction in morbidity and mortality. What's the difference in GLP-1 receptor agonists?
Yeah, that is a really good question. So many experts were thinking first it is increased sympathetic tone. That would be bad, of course, in heart failure. We don't want that. And but now with this data, with the pacemaker cells in the sinus node, so this target is a little bit away from the sympathetic nervous system. But at the end of the day, I don't think that we really can tell why this is the case. But I think it's important to recognize, and it is also reassuring to see that exercise is counteracting. I don't know by which means, but it's counteracting this increase in heart rate. And that's why it's really important to do exercise when taking these drugs.
Do you take any clinical actions when you see an increase in heart rate? Okay, you recommend exercise, that's something you do anyhow, but would you uptitrate beta blockers? Would you put patients on ivabradine if you see an increase in heart rate and HFrEF?
Well, there are no guidance in this regard, but I personally would not go with the beta blocker in this situation, definitely not. If I cannot resolve it with exercise, then ivabradine, I think, would be maybe the choice. If we think it's really the sinus node, then that would be the target.
And can you say something about the combination of, let's say, SGLT2 inhibitors and GLP-1 receptor agonists? Is that something you do commonly? Is that something you do only in reserved patients? Do you start with the one or the other? What's your clinical guidance there?
Well, theoretically, that's a very good thing. So they are complementary. They have different actions. And we know from the studies, from the GLP-1 studies, that the subset of patients that was taking SGLT2 inhibitors got the same effects out of the GLP-1 therapy. And on the other hand, from the SGLT2 inhibitor studies, we also know that these patients that were on the GLP-1 agonist also got the same benefit from the SGLT2. It's more a problem of insurance companies, and I think the endocrinologists deal much more with that. So in a diabetic patients, we have really better chances to establish both drugs. In a heart failure patient without diabetes, it's very difficult.
Ottmar, you showed very nicely the positive effects of GLP-1 agonists. Have you seen in your clinical praxis many side effects? So did you have patients where you had to stop it?
Yeah, I think it's mainly the gastrointestinal side effect, and this is also evident in the study with this 8% increase. And that's why it is really important, and it's mentioned in the compendium, that you really go slow. You start with a very low dose in semaglutide 0.25, and then for 4 weeks, and then you increase to 0.5, and again 4 weeks. So you should go very slow. And then if a patient really tells you that he has problems, then maybe you rather stop on that and don't go further, because if you go further, you might lose the patient. And you don't really have to go in all patients up to 2.4. There are also good data for lower concentrations, especially the flow trial, they did not use 2.4.
Just one quick question. The main issue is of GLP-1 agonists, if they stop taking it, they gain weight again. So do you have in your clinical practice any solution how to deal with that?
No, unfortunately not. I think they have to keep on with their exercise training. and there are more and more data coming that stopping right away is a bad idea, because then the rebound is coming for sure. But now it's more going in this direction, that you go down slowly with the concentration, and then maybe you are not completely off the therapy, but you lose less amount of drug, and that makes it all at the end of the day cheaper over the year to do that treatment.
Okay, thank you very much, Ottmar.
Thank you.
We're coming to the last presentation of this year's ESC update, and it's my privilege to introduce Professor Philippe Cartin, who is the director of the Department for Biomedical Engineering, and he's talking about a topic of much interest also for the medical community, which is machine learning in medicine, and we very much look forward to your thoughts as an engineer on that topic.
Okay, thanks a lot. I think you already revealed the big secret. I'm not a medical doctor, I'm an engineer. And I'm heading this department. Just a few numbers that I put on it. So we have like 270 researchers that are, half of them are mainly from a natural science background, not medical doctors, or most of them, but we are part of the medical faculty, and we support the medical faculty, the professors, the researchers, the doctors here with our technical solutions. I myself, as Felix already mentioned, I'm heading a group that is developing AI solutions mainly for the two hospitals, USB and UKBB. And some disclosures: I have no financial relationships to anything what I report. These are all purely research-related activities that I'm showing, and I'm giving a talk about AI, but I did not use any AI to prepare this talk, so it's purely manually made. So what is the objectives? I will give you some definitions, some examples of AI in cardiology, and then what is, I think, the main take-home message for you are the challenges when applying these AI tools. I think this is very crucial for you to understand, and I know I'm the last talk between you and the apero, but bear with me, I think it's quite crucial. This is a slide I took from another talk of mine, just to show you a little bit the onset of artificial intelligence. It started in the I have to point here, I was told, in the 1950s, but now there has been a huge spike in the last couple of years, and this will most likely continue like this. So it was actually invented in the 1950s, and here you see some of the names: Alan Turing, Claude Shannon, Walter Pitts, McCulloch, and especially Marvin Minsky. Minsky developed the first artificial neural network that you can see on the right side. He made it out of electronic components because computers at that time were not yet available and fast enough. So he made the first neural network. Nowadays, we use a little bit different designs, and I'll come to this. And then at the same time, Alan Turing, and this is probably something you heard with all the discussion about the LLM, you probably heard about this Turing test. So this was also invented in the 1950s, this Turing test, and the idea was, how can I recognize that something is intelligent? So how can I quantify that or measure it? And the idea that Turing proposed is that we basically take a person C, and this person C is talking about any topic with two entities, but he doesn't know whether these entities are either a person or a computer, but they can talk about any topic, so they just pass on written notes, and if the person C cannot distinguish the human from a computer, this is intelligence. This was the definition that he proposed in the 1950s, and it has been used a lot in the news with these LLMs, that we actually achieved this goal by now. But why did it take so long from the 1950s until now with the big onset? Because the basic ideas were already there in the 50s. And the problem was, And this resulted in some hype cycles. In the 50s, there was a big hype. Then there came the first winter, as we call it, AI winter. There was another hype with these expert systems where you had manually designed rules, which is quite similar to the differential diagnostics that you're using. So we programmed computers like this to solve tasks. So there was another hype, another winter was coming. And actually, it only took off in 2011. And the reason was that these GPUs, or general graphics processing units, became available. So these are basically additional processing units in your computers that were mainly made to produce graphics for gaming industry. Or for if you wanted to play games at home, you needed such a GPU. And in 2011, two researchers had the idea we can use these to train neural networks. So this was the first game changer. The other game changer was the wide availability of additional data. YouTube, Instagram, all the medical data that was collected. So we had access to a lot of data, and this is needed for deep learning, AI. But there were also some important algorithmic advances. So research invented solutions to these problems. I will not go into detail, don't worry. But there were still some challenges we had to face to train these models, and these are basically the four main problems. So how do these computers model it? I think it's based on the nature, but we just have it implemented on the computer. So we have a neuron here, as we call it, and we have connections from other neurons here. And we have weights here, this W0, W1, W2. And then the equation that we use in here is pretty simple. We just weight it. The input value, we weight with this W, W0. So this is this input weighted with W1, so from the neighboring neurons here. And we sum everything up, and then we go through an additional function, which might be absolute value or something super simple. And this is then the output, and we make huge networks of these. So that's the whole secret of it. This has been known definitely since the 1970s. The perceptron, as it's called, has been developed. Nowadays, since we, as I said, we work on these GPUs, we use a little bit different ways to note it down. So if you had an image, for example, over here, so this image, and this is now from face on, when you look face on to this image, you can see this image is composed of pixels. And what we actually have here is filters. So these are just 3 times 3 or 9 values here. And then we shift this yellow box here, this filter, over the image. And whenever, at each location, we take these as the weight, we multiply it with the pixel value here, we multiply this weight with the pixel value here, this weight with the value here. So for all 9, we sum them up, and we put it in the output matrix here. So we do this for all these images. So that's the one layer in these networks. And the second layer is that we take, this is the max pooling, so we take 4 of these values, and we, for example, take the maximum of these. So we reduce the image size. This is called the CNN, super successful. I think these were the first network that really hit the road and were super successful in recognizing images. And this is basically, you now know, from a mathematical point of view, this is the entire secret of deep learning. So we just need to know these filters, and then we can train a network as here to recognize characters like these letters here. And we just have several of these filters. So these are basically the weights that we have to train. And I will show you now then how these networks are trained. But first I will give some background about the words that I use here. So as I said, artificial intelligence, this word was invented in 1960s, 1950s. In the 1980s, machine learning was quite a popular term. This is basically the functions that sorts your emails, or the technology that sorts your emails into into spam or not spam. Then came the neural nets that were used to recognize letters on your written letters. And since about 2012, we have a deep learning, which basically just meant we have now the algorithms to make the networks a lot deeper. So that's the only change. But these words are used interchangeably. Normally we use artificial intelligence. It's quite often. But if we use AI, today we mainly mean deep learning. How does it work? So I told you before, artificial intelligence methods, they, before these expert systems, this was basically the differential diagnosis where you had rules. If patient shows this symptom, have temperature above this and that, then do this. And today this works completely different. Today we take a lot of data, we gather all the data we have, and then we split it in at least two different sets. One is the training set. One is the training data set, and we have the testing data set. So what do? With the training data set, we basically feed in one of our data sets, could be an ECG, into our system. So this is our black box, so this is the AI. So all these filters that I have been showing you, and we look what the output is. The output is, when we start in the beginning, it's not the correct output. So what we basically do is we change these weights here, and I try to symbolize with these levers here and knobs here, I try to symbolize the weights. So we adapt a little bit the weights. We feed in another ECG or a number. We see what is the outcome. Is it correct? If it's correct, it's fine. If it's not correct, we try to change a little bit these weights. And this is what we call the training phase. This takes a lot of time. This training, this can go from minutes for simple signals to large language models. They train for a year, for example. So we do this training until the weights are such that we are satisfied with the solution. If we feed in a 2, that he basically comes out with a 2. Once we have this, we can go in production time. We can now set it up in a post office such that it automatically recognizes the zip codes. So this is a stark difference to what we had before in these expert systems. We don't design our rules ourselves manually, but we basically completely shifted the paradigm. We let the neural network figure out the rules. And this was the big game changer to previous AI solutions. Now the network chooses what is best to solve a task. But you have to be careful because they also cheat. And they're masters in cheating, neural networks. We had data sets from Basel here from patients and healthy volunteers. We did not have enough data, so we took an MR data sets from Lausanne, but these were all healthy patients. And then for the neural network, it was super easy. It was super good at finding out if somebody was healthy, especially from all the data sets in Lausanne. He did not even look at the pixels. He could see from the gray value distribution, he could tell, okay, this is a data set from Lausanne, so this patient is healthy. So he did not look, and there's other examples where they try to robots to self-teach how to walk, and then suddenly a robot used 0 steps to go to the target, and when they visualized how he does it, he was basically walking on his elbows. So he did use 0 steps, and he fulfilled the goals optimally. You have to be really careful on that, but this is normally not the problem that you have, but this is issues that we solve. Now a little bit more to your field. So where are the areas that artificial intelligence, deep learning is used? And I think you all agree with me that all these pacemakers, defibrillators, they have some intelligence inside. And there is a review article that I mentioned here that shows that with AI you can improve the decisions that these devices make. I think this is a slow process that is unknown to us. However, we have to be very careful, especially for the pacemakers that are implanted. The power consumption, these AI algorithms, they use a lot of computational power for training, a lot less than for the inference when you use it. But in a pacemaker, you have to be super careful with available power. So this is something that one has to consider. And then this, I'm sure you know as well, since Apple version 4 of their iWatch, they had in 2018, they had FDA clearance to use it for an ECG, and in 2020, the blood oxygen measurement was available in the watch, but it's still a wellness device. It's not a medical device, because the hurdles to certify this as a medical device would be a lot higher. And there have been companies in Switzerland that have been trying to do this. Unfortunately, it did not work out. They tried to first introduce such a wearable device for women to predict on when they're it's best to receive a baby. And I don't know the medical term, sorry. They wanted to introduce this first as a wellness device, and then once gather a lot of data, and then at some point make a medical device out of it. Unfortunately, they went broke before they could make a medical device out of it. As you know, many of you know that you can now send in these Apple Watch ECGs to University Hospital in Basel. They will analyze them. I don't know to what extent they use AI. It's probably manually. Definitely they have to do an end check in these systems. And we also tried to hop on this train together with Jens Eckstein, a cardiologist also from here. We said, okay, if the ECG of this Apple Watch is so good, because this came out of a colleague of Jens Eckstein that was calling him. He had suspected some heart issues, but he was on a remote island somewhere. And then he tried to direct him to place the Apple Watch in specific locations, such that he has like a 9-lead ECG. And he managed to do that, and we developed an AI that was then automatically showing patients where to put these leads. And this is something we did, and we tested it here in Basel with 50 patients, and all of them managed to place them. I think 86% of the ECG signals that we recorded were perfectly usable. So this is something you can do. This is now using the selfie camera. So you position your cell phone in front of you with the selfie mode, and then he tells you where to hold your watch for, I think it's 20 or 30 seconds. We also did some this was cardiac surgery, some risk prediction, because this is also, I think, a topic that will be very important for you in the future, not just on the diagnostic side, but also for risk prediction. Here we compared the Euroscore risk prediction after cardiac surgery to one that the AI found, and I think the performance was quite good. So all these orange points are where the patient died, and AI gave most of them a very good score. There's definitely some outliers here, but the outlier down here, I heard he unfortunately fell down the stairs. Hopefully not because of cardiac issues. But this is definitely an area where you have to expect in the future that AI will support you in making predictions. So I've also looked at the review article from electrocardiology to see a little bit what can you expect. And I think that there's probably not a single diagnostic topic that is currently not covered or researched to use AI on these methods. But also cardiac ultrasound is a topic. This is also a movie from our own research with Rolf Vogel from, at that time he was at Inselspital, where we basically made an AI system that was measuring how fast the microbubbles reappear in the myocardium after it has been destroyed with the ultrasound. So you can also expect in the future that all these AI algorithms will help you in getting quantitative features out of your ultrasound images. However, as an image analysis guy myself, ultrasound images are not our preferred modality. These images are really difficult to automatically process. They're the most difficult ones. So MRCTs are a lot easier. So open challenges, and so this is fairness is an open challenge, and bias. We've already heard in the first talk today, bias, women, male, and here Google tried to compensate for this bias a little bit. They overdid it a little bit, because when you ask Google Gemini to produce an image of the founding fathers of the United States, they added an African-American person. Obviously, they were not part of the founding fathers, but they tried to compensate for this bias, and sometimes you overdo a little bit, and this is really a problem, because bias is in your data. I read about a study that MIT did with chest x-rays. You see in the chest x-rays the race of the person. So it's really quite amazing what these systems can do. And they try to distort these images, filter these images, and the systems, AI was really good at detecting this. The other one is that you have to be aware of, or what we actually have to offer you, is explainability. Here you see, this is from a paper that was estimating the ejection fraction. But for you as a user, it should not be enough. What is the expected ejection fraction from the ECG? But you also want to know exactly why he came up with this solution. And this is something that you should expect in the future, that these systems not only tell you he has this disease, but should also help you to understand why he came to this conclusion. And this is still ongoing research. There's also adversarial cases. I did not find one in your area, but this is obviously a panda on the left side. But when you add a little bit of noise, and this is the noise pattern, and this is the panda with the noise pattern, but AI now suddenly thought this is a monkey, a gibbon. And this is, of course, probably more problematic when we are speaking of self-driving cars, because you could add such a noise pattern to a sign, a speed sign on the motorway, and suddenly AI thinks it's a stop sign, and then your car stops on the motorway. So there's all kinds of nasty things one can do. Medical certification is still a little bit of an issue. We have now the process here, and in 2 weeks we will send in the first AI algorithm that we certified here from within university hospital, but it's a pain still. So it still has to become better and faster. And this is super critical for you, the integration into the medical workflow. This is key. We develop lots of solutions for the medical doctors. Here in the university hospital, we mainly work with very motivated people, but when you're working with from day to day with patients, whatever you use should make your life easier. And this is also what we actually try to do. We try to develop together with our doctors here solutions, and all AI solutions should actually make your life easier and not harder. And this is nowadays still not always the case. So what can we expect? I think better patient care in the future. More patient-specific treatments. So we have research, for example, with the surgeons, where we try to predict from preoperative data what approach should they use. And this the same could be used here. Should we replace the valve? Should he go from cardiologists? Should he go to the cardiac surgeons? So probably these systems, they can help a little bit to in these treatment options, but should always explain why he came to this conclusion. Predictive analysis, so to predict events beforehand, this is something that we should expect. Patient engagement, so in the future we can follow the patients through cell phone, through the watches. I'm pretty sure that this is not only already here, but this will only improve. And AI systems will also be able in the future to integrate more of these modalities. So ultrasound images, ECG, and patient data all in one, and then make one conclusion. I think this is what we can expect in the future. So AI will definitely become a part of clinical routine, but I don't believe it will replace you. Definitely not in the near future, because you have to understand what the biases are, what the limits are of these systems. We have to explain you what the limits are of these systems, and there still needs to be a human in the loop that basically makes these decisions. And this is why it's very difficult to introduce new systems into the hospital for us. We don't want the residents to just blindly trust. If it worked for 3 patients, they probably, if they're under pressure, they might just accept what the AI tells them without thinking on their own. And this is something we have not yet found solutions. How can we help you with AI solutions while still keep you in the loop active and not just blindly trust them? We need multi-center, diverse, high-quality data sets. This is, again, to avoid the bias. And we would need share our data, more open systems, open EHR. As an AI researcher, I'm not too happy with all the hospitals going to Epic with their closed system. There is open EHR. There is a standard how you can openly store. Denmark is using it widely, and this is super cool. If we need a lot of data, we can ask our Danish colleagues. They can grab the data from a lot of hospitals very easily because they use open standards. I think we should also come to this conclusion that for AI we need these open systems. And we expect that gold standards might in the future change with this additional knowledge that we can learn and generate from AI. Okay, with this I would like to thank you for your attention. I'm open for questions.
Thank you very much, Philippe. Other questions? How far away are we from fully automated assessments of CTs and MRs and pathology, stainings, and these kind of things?
I think when you look at very specific systems that have been designed for very specific tasks, these systems are very good already. So if you need to segment a tumor or so, I think this is largely a solved problem. It automatically finds these tumors, segments it. But if you just take any CT and ask the system, what's wrong with this patient? This is still too far away. Now, you ask me, when will we have this? This is difficult to say. I would not dare to give you an estimation on when we will have this. But I assume I will be retired before that.
Okay.
But I don't recommend my daughter to become a radiologist. Sorry.
Thank you for this great presentation. I have a question regarding medical certification. So you apply once with your AI algorithm for certification,
yes,
and then it's a dynamic process. You improve it, and then you have to recertify, or how does it work?
Yes. Today's systems that have been certified, they are not self-learning. This is something that many people misunderstand. You basically certify, as I explained you, the weights in your black box. You basically certify these weights, and you have to show on many data sets that these weights produce useful results. But it's not that if you with the algorithm adapts to your patient population. So these systems we cannot yet certify. So we certify a fixed system. If we train new system with new data, we have to basically recertify it again. At least do part of the, so there's this traceability matrix that shows you what you have to do from the whole process again to show that it's still safe and effective. But there's no self-learning systems available right now.
And I have another question. As you showed that AI increased significantly in medical research, everybody is doing AI at the moment. And maybe this is too difficult question, but is there like at first sight, how can you judge if the AI is performed properly or somebody is just calling it AI, but it's actually not AI?
Yeah, I don't remember the exact number, but I heard that many spin-off companies, they use the buzzword AI. But in the end, when you check it out, only half of them, I think it was like this, used AI, and the others just did Wurstle in Swiss German. Now I forgot the question. How can you identify this? Yes. I think I would estimate that there's now guidelines from the EU that were drafted on how you should evaluate and document your AI systems. So if I would not trust a company that just gives you a black box without telling you how they did it. They should be open to what data did they use to train. This is, for example, you don't get from all the LLM companies because they just stole the data from New York Times and other newspapers and trained their model. So this is why they don't tell it. But they have to be open to what data they used and how it was trained, what algorithm they used to train, and how it was tested. I think this is a measure of quality that you can, that you should expect from a decent system. Not just a black box and it does magic. Yeah.
I was a bit shocked by the gibbon panda story that you told us. Taking that to medicine, I would think, let's say we do a CT, and it works in detecting lung nodules in Basel, but then someone in Zurich uses the algorithm with a different CT, maybe from a different company. How do you make sure that minimal standards are met?
Yes, this is something you have to test when you certify a medical device. Either you, for example, we certified now one for MS lesion segmentation automatic, but there we said it's only used in Basel. So we trained it on Basel data, we showed on Basel data that it's working, and then when you go to another location, you have to show that it's working. If you want to make a medical product out of it that you sell worldwide, then there's lots of countries where you have to show it also works on Hispanics, on African ethnicity. So you basically have to show that it works on all these ethnicities that you claim it works. But you can only show it on examples. It might always be the case that you have an anatomical freak that does not work, and this is why we always need the human in the loop. And this is why I fear, why I struggle a little bit introducing these systems into the clinical routine, because there still has to be a human in the loop.
Okay, thank you very much, Philippe, again.
Thanks as well.
I'd like to conclude this session and conclude this year's ESC update by thanking Christian Müller and the Scientific Committee for organizing, setting up this entire full program, which was very educational, I think. It was interactive, so thank you for coming. Thanks for the presenters for excellent presentations, for lively discussions. Have a nice evening, and we all hope to see you soon again here in Basel. Thank you very much.